Yes, ma'am. आस्तीन में अब भी वो अदब और जज्बात लिए फिरती हूँ, रहूं कहीं भी थोड़ा सा लखनऊ साथ लिए फिरती हूँ। इस नफासत और नज़ाकत के शहर की मखमली सुबह मैं आप सभी का हार्दिक स्वागत करती हूँ। Setting the tone for the day with this Lucknowi welcome note, a very good morning to this August gathering. As we tread into the second miraculous month of this magical year, let us all take a moment to appreciate the epiphany of our hearts and the rhythm of our soul that syncs perfectly with the universe to orchestrate the enchanting chemistry of life. Directing our light graciously towards gratitude, the next chapter ahead is definitely a brighter one. On this note, I, Shreya Palit of MBBS Batch 2020, am privileged and delighted to welcome one and all to the workshop on advances of cytogenetics in clinical applications organized by the Center for Advanced Research, King George's Medical University. Cytogenetics, being an emerging field of interest and finding immense application in the diagnosis of diseases, has grabbed our interest since times. This international conference cum workshop will throw light on all the aspects concerning the diagnosis of chromosomal abnormalities, and the hands-on training is indeed a global opportunity to master the quintessential techniques in the field of cytogenetics. It is rightly said, the acknowledgement of the good we are blessed with is the highest form of thought, and gratitude is happiness doubled by wonder. Acknowledging the same, I would now like to welcome our esteemed dignitaries with flowers as a token of our affection and respect. Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri, sir. We welcome you, sir. Professor Amita Jain, ma'am, Faculty in Charge, CFAR. We welcome you, ma'am. Professor A.K. Tripathi, sir, Dean, Faculty of Medical Sciences, KGMU. We welcome you, sir. We are also privileged to have amongst us Dr. Abbas Ali Mehdi, Dr. Punita Manik, ma'am, Dr. U.S. Singh, sir, Dr. Amod Kumar Sachan, sir, Dr. Sharad Singh, sir, Dr. Anuradha Nishchal, ma'am, Dr. Rashmi Kushwaha, ma'am, Dr. Rima Kumari, ma'am, Dr. Rajni Gupta, ma'am, Dr. Amita Pandey, ma'am, and our erudite panel of speakers from various universities across the country. Dr. Inusha Panigrahi, ma'am, Dr. Freni Sheth, ma'am, Dr. Shruti Agarwal, ma'am, Dr. Arundhati Sharma, ma'am, We are indeed privileged to have this panel of experts and intellectuals amongst us today. We welcome you, sir and ma'am. Shubham karoti kalyanam arogyam sukh sampadam drashti buddhi vinashaya deepajyoti namostute atmajyoti pradiptaya brahmajyoti namostute brahmajyoti pradiptaya gurujano namostute. On this note, I would now like to humbly request our delegates on the dais to kindly commence the program by lighting the ceremonial lamp. Sir, ma'am, please. Thank you, sir and ma'am. Having evoked the blessings of Goddess Saraswati, let us now seize the day with all our might. I now humbly request our respected faculty in charge, Center for Advanced Research, Dr. Amita Jain ma'am, to kindly present the welcome address. Ma'am, please.
Our chief guest for this conference, Lieutenant General Dr. Vipin Puri sir, Honorable Vice Chancellor of King George's Medical University, our Dean, Medicine, Professor A.K. Tripathi sir, august speakers who have traveled across the country for this symposium and workshop, our very, very illuminous faculty of King George's Medical University, delegates who have traveled all across the country, and our dear students. It's my privilege and honor to welcome all of you for this academic feast. The Laboratory of Cytogenetics, which is a part of Center of Advanced Research in King George's Medical University, is one such laboratory which provides diagnostic, management, and prediction for the diseases where genetic signatures are important. So we look for the changes in the genetics of the cells which can help us diagnose, predict the outcome and the management of the diseases. This is going to be a really important area of expertise for all of you who are going to be here for this 5 days workshop and 2 days symposium. I welcome all of you on this beautiful February morning of King George's Medical University, and I would request all of you to please go and have visit our campus, which is really booming with flowers and is very, very beautiful. So at this note, thank you very much for being here and welcome for this workshop. Welcome everyone.
Thank you, ma'am. Your words have indeed set the vibe for this intellectual venture. I would now like to request our who has been a constant source of motivation to kindly address the gathering. Sir, please.
Professor Amita Jain, faculty in charge of the Advanced Research Center, Dr. Neetu Nigam, the organizing secretary of today's workshop, eminent speakers, guest faculty, Dr. Fremi Sheth, who's the Director, Institute of Human Genetics, Ahmedabad, Dr. Ashutosh Haldar, Head Reproductive Medicine at AIMS. He's not yet come, has he? He's on his way. Dr. Arunati Sharma, Dr. Inusha Panigrahi from PGI Chandigarh, and Dr. Shruti Agarwal. So very, very eminent, iconic guests we have for today's symposium come workshop. Friends, ladies and gentlemen, I'm very honored to be here this morning, to be a part of this inaugural function of this cytogenetics and personalized medicine vertical from CFAR, the Center for Advanced Research of this university. Very happy to be hosting this international conference come workshop on advances in the field of cytogenetics and its evolving spectrum of clinical avenues, applications, that what Professor Amita talked about. Well, let me begin by saying that cytogenetic analysis, this is for all my students, residents, and the faculty, the junior faculty who's here. So I think it's very important for us to move forwards, continue with the evolving diagnostic and the investigative mechanisms which are evolving at the molecular level. And I think it's very important that we in this university keep a track of this. And cytogenetic analysis, as you're all aware, has been utilized worldwide to diagnose chromosomal issues, problems, whether it's duplications, deletions, dislocations, translocations, inversions, etc., etc. So huge amount of chromosomal aberrations to translate the anatomy into disease, presence or absence of disease. And as what Professor Amita said, is it only diagnosis? Is it management with targeted therapies? Or is it prognostic? Where can you prognosticate what's going to be the actual fallout of the management protocol? So I think all of this is an emerging science, and I sincerely believe that the science is increasing exponentially by leaps and bounds. And as you're all aware, all this started. This is just about what 5, 6, 7 decades now. I think it all started something in 1956. As I was reading, when they found the chromosomal mapping, and they said there's 46 chromosomes in the human genome, and trisomy 21 was actually picked up in 1957 when they found that there was something amiss in the genomic structure of the Down's children. Then the presence of this 922 translocation found in CML in 1959 brought about what we now call as the Philadelphia chromosome, and thereafter started an array of different things in terms of treatment modalities, targeted therapies, and that was yet another beginning. So today, as we look at cytogenetic analysis, as I say this, it is actually more towards precision medicine, personalized medicine, as we try and target that subset of patients who are not conforming to the natural principles of treatment. So it is that subset who can be analyzed, where your genomic structure, your anatomy, your genomic at the cellular level can be analyzed. So I was reading with great amount of interest. A lot of techniques have emerged, be it the fish karyotyping, the copy number variant assays, microarrays, etc., etc. So huge amount is happening, and of course the experts today are going to talk about all of this. I was particularly very fascinated by this optical genome mapping, which I'm told that it brings together, amalgamates a lot of these things together, and where you can see long stretches of the DNA in one single frame. So I think it's technology has come in at the molecular level as well. And now, the point which I'm trying to make is that as technology comes in at the molecular level, it's AI stoops in here also. So it is AI which is now taking down the genomic mapping, all your variants, all your chromosomal aberrations, and putting it so without too much of if you just go through these algorithms, the algorithms which I'm told are already in very, very advanced stage, I think you would be seeing the next generation sequencing in molecular genetics, where by by preliminary methodologies you'll be able to diagnose. So I think a lot is happening, but what is important is that the genetics people, the cytogenetics people, the cell biologist people, and the bioinformatics people, I think they all have to come together, put their minds together for us to have a consensus statement. How do we together take the science to a different level? And with these few words, I once again congratulate the Center for Advanced Research, Precision Medicine, Professor Amita Jain, and of course Neetu, who has been the brain of this entire exercise. I congratulate you in the way you have constructed and structured this program. And I remember when I was in the forces, I used to tell everybody that this is the way it should happen. A hands-on workshop. Because, you know, as you say, if you just hear, you normally forget. But if you see, you sometimes remember. But if you do, you actually understand. So I'm very happy that it's a hands-on workshop. I wish this workshop symposium a grand success. And to all our esteemed delegates who have come from across the length and breadth of the country, on behalf of the university, I extend to you a very, very warm welcome. Thank you, ladies and gentlemen.
Thank you, sir. I am sure the audience will agree that sir has motivated us to dream more, do more, and become more. It is rightly said that memories are timeless treasures of the heart. To preserve the memories of this beautiful day for times immemorial, we would now like to present our respected dignitaries with mementos as tokens of gratitude and reverence. I would now like to request Professor Amita Jain ma'am to kindly present the memento to our Honorable Vice Chancellor, Sir, Lieutenant General Dr. Bipin Puri. Ma'am, please. We are grateful to you for sparing your precious time to grace the occasion, sir. Thank you, sir and ma'am. I now request Professor Anuradha Lishchal ma'am to kindly present the memento to our Honorable Dean, Faculty of Medical Sciences, Professor A.K. Tripathi, sir. Ma'am, please. We are privileged to have you amongst us, sir. Thank you, ma'am and sir. I would now like to invite our respected Organizing Secretary, Dr. Neetu Nigam ma'am, to kindly address the distinguished assemblage. Ma'am, please.
Good morning to all the august gathering. The successful beginning of this day of our workshop fills my heart with the pride on witnessing our incessant efforts falling together beautifully. I would like to extend my heartfelt gratitude to our Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri sir, for giving us the opportunity to put together such an enrichment event. We are blessed to have Professor Amita Jain ma'am as our respected faculty in charge, CFAR, who has been a constant source of motivation. I am also thankful to our Dean Academics, Dr. A.K. Tripathi sir, for his constant support and guidance. I express my sincere gratitude to our eminent guests and scholars from across the countries. I am sure the participants and audience will agree with me that witnessing their sessions will indeed the most enlightening experience. So have a great day to all of you, and next session would be the scientific session begins. Thank you so much. Cytogenetics करते हैं इसके अंदर फोल्डर में ऊपर तक और फोल्डर ऊपर हाँ ये इसके अंदर क्रोमो क्रोमो निकल साइटोजेनेटिक्स फाइनल 26 ये वाला कॉपी
मैम की कौन सी है दूसरी
Without any further ado, let us now step into the much-awaited Scientific Session 1. I request our respected chairpersons for Session 1, Dr. Anuradha Nishchal ma'am and Dr. Reema Kumari ma'am, to kindly grace the dais. It is my honor to introduce to you our respected chairpersons for the session. We have with us Dr. Anuradha Nishchal ma'am, who is a professor in the Department of Pharmacology and Therapeutics at King George's Medical University, Lucknow. She is also the coordinator for the ADR Monitoring Center under the aegis of National Coordination Center, Pharmacovigilance Program of India, Indian Pharmacopoeia Commission, Ministry of Health and Family Welfare, Government of India. Additionally, she is also the superintendent cum faculty in charge, Hospital Revolving Fund, King George's Medical University, Lucknow. She has been an active member of various university programs, including Medical Education, Waste Management Program, Women Harassment Committee, Institutional Ethics Committee, and the ADR Subcommittee. She has conducted various training programs in soft skills within the King George's Medical University as well as outside KGMU and also in international conferences. She has also received an award for excellence in training in soft skills at ICDS, Kandy, Sri Lanka. It is an honor to have you amongst us, ma'am. We also have with us, as the chairperson for Session 1, Dr. Reema Kumari, ma'am. She is a professor in the Department of Community Medicine and Public Health, King George's Medical University, Lucknow. An alumnus of KGMU, ma'am has more than 55 publications in national and international journals to her name. She has also received the coveted scholarship from the UGC, New Delhi, for the Indo-Hungarian Education Exchange Program to visit Budapest, UK, Hungary. Ma'am has also received the Global Academic Society Award and AICTE's Leelavati Award, New Delhi. She has also received a Recognition Award and Certificate of Excellence for contribution in transforming KGMU into a regional model institution for sound BMW practices by UNDP, GEF, Global Healthcare Waste Management Project, supported by WHO and HCWH. It is an honor to have you among us, ma'am. I would now like to hand over the proceedings to our honorable chairpersons for the session. Ma'am, please.
Thank you, Dr. Shreya. It is an honor for me to be here this morning to chair this session. Also, it is my proud privilege to introduce Dr. Inusha Panigrihi Madam. Dr. Inusha Madam is a professor, Genetic Metabolic Unit, Department of Pediatrics, Postgraduate Institute of Medical Sciences at Chandigarh. Ma'am has been associated with great institutes like IMS BHU, SGPGI MS, All India Institute of Medical Sciences, and PGI MER. And she has been...
There was to present the first talk, but his flight has been delayed. So I'll be presenting first. So the gold standard for chromosomal disorders, as everyone knows, is karyotyping. But now more number of tests have become available. So when do you suspect a chromosomal disorder? So when there is a constellation of clinical features consistent with a known disorder like Down syndrome, Turner syndrome, or Klinefelter syndrome, when there is a dysmorphism with the associated cardiac defect, you can think of DJOG syndrome, Williams syndrome. Then when there is a dysmorphism with a significant low birth weight and microcephaly with or without behavioral problems, you can suspect deletion duplication syndrome like villocardiofascial syndrome or 1p36 deletion syndrome. And when you have bilateral clinodactyly and semen crease, these are pointers to a chromosomal disorder. Then you can also think of a chromosomal disorder and do a chromosomal workup. or there may be pigmentary lesions with asymmetry where there can be somatic mosaicism. So you can study like a skin biopsy for any chromosomal abnormality. Then if there is antenatally detected cystic hygroma or increased nuchal fold thickness, then again one has to rule out Turner syndrome, though a close differential in this case would be Noonan syndrome, which is a rhasopathy. So when there is an unexplained ID with dysmorphism, the first line agent, first line testing, which is advocated nowadays, is a chromosomal microarray. So different tests are done for these chromosomal disorders. We'll go into the details in this presentation. So what are the indications of a chromosomal analysis? So when you are planning a prenatal diagnosis for chromosomal disorder due to abnormal serum screen or due to ultrasound abnormality, then one can do a karyotyping or a chromosomal microarray. Then when we are thinking of multiple congenital abnormalities and there is also additionally some dysmorphism, then it can be a malformation syndrome and also a chromosomal syndrome. And when you have sexual ambiguities or abnormalities of sexual development, then also you can think of a chromosomal disorder like Klinefelter syndrome. When you see patients with infertility, recurrent miscarriages, especially in case of recurrent miscarriages with early abortions, early miscarriages or early fetal losses, in that case you have to do testing for balanced chromosomal translocation, and for that the test is karyotyping. And when we want to look for a chromosomal breakage syndromes, there is a separate test which you can do, that is the chromosomal breakage test. Unexplained mental retardation, unexplained stillbirth, patients with leukemia, lymphoma, solid tumors, in all these clinical conditions, again this chromosomal analysis is helpful in giving a diagnosis or a prognosis, and it can sometimes help in the further future prevention in that family. So the chromosomal disorders can be either aneuploidies, when there is a discrepancy in the number of the chromosomes, so it can be monosomy or trisomy, and chromosomal translocations can be there, as I told, in case of recurrent spontaneous abortions or recurrent pregnancy losses. You can get deletion duplications in patients with especially intellectual disability with or without malformations. You can have paracentric and pericentric inversions, ring chromosome. You can have different microdeletion, microduplication syndromes. You can have subtelomeric rearrangement in a subset of patients with intellectual disability. And these common disorders include Down syndrome, Turner syndrome, Klinefelter syndrome, Fragile X syndrome. This most of the people must be knowing. And Prader-Willi syndrome is a common genetic cause of obesity. And Edward is trisomy 18. So different techniques are used for detection of these chromosomal disorders, and karyotyping, as you know, is the gold standard and it is traditional technique, and still it has applications in this molecular era. A FISH is a fluorescent in situ hybridization. In selected categories of disorders, one can go for FISH to identify a particular segmental abnormality. And MLPA is done usually for known deletion duplication. There is a specific kit, P245 kit from MRC Holland, which can be used for detection of the common deletion duplications. And chromosomal microarray is usually done when you want to see known and unknown deletion duplications. And you can also detect LOH, that is areas of homozygosity. And then latest is the NGS assay, which can be tailored to detect copy number variants also, apart from the single nucleotide variants. So Down syndrome, as you know, is a common cause of intellectual disability occurring in both males and females, and it is a common cause of intellectual disability. There is an increased frequency with advanced maternal age. Usually the cutoff taken is 35 years, and there are different types of Down syndrome subtypes, which include free trisomy 21, translocation 21, or mosaic trisomy 21, though the manifestations will be similar in all these cases. And 95% of Down syndrome are due to free trisomy 21, and risk of recurrence would depend on the type of the defect. So this is the flat facial profile. You see small ears, flat facial profile, protruding tongue, open mouth, and mongoloid eye slant, and simian crease that can be clues to diagnosis of Down syndrome. And this is an older child who was treated with leukemia. Leukemia is more common in children with Down syndrome. And you can see the peripheral features like sandal gap, increased space between the great toe and the second toe, plantar crease between the two toes. And so these all give clues to Down syndrome. In karyotype, you can get free 321 chromosomes as highlighted here in the karyogram. And this was the traditional technique which was used earlier. Now you have a advanced image analysis system which can be used to better identify these chromosomal imbalances on a karyotyping or fish. So this is the translocation 21. So 21 chromosomes are joined together, giving 3 copies of chromosome 21. Normally there should be only 2 copies. And in Turner syndrome, you have short stature, delayed puberty, primary amenorrhea, increased carrying angle, and these can be identified again. If you want to confirm, one can do a karyotyping and identify whether it is a real monosomy like absence of 1X chromosome, or there is some structural rearrangement which is causing Turner syndrome. So the girls with the 45X or monosomy X patients have in 26% ovaries detected by ultrasonography. 25% of the girls will be showing some signs of puberty. 6 to 10% can achieve spontaneous menarche, and in mosaic Turner, 76% cases have detectable ovaries and large ovarian volumes, and 38.5% achieve spontaneous menarche overall. So, and many of these, however, will need support, hormonal support therapy, and also support during pregnancy. And this was one child with Turner syndrome. Usually, we don't get significant dysmorphism in Turner. However, if there is a ring X chromosome, you can get dysmorphism. Then Klinefelter is the another aneuploidy which you get, and in this you can get tall stature, hypogonadism, infertility, psychiatric problems, intellectual disability, and there is extra X chromosome in the males, though there it can be also in the mosaic state. The growth of pubic and facial hair is often late. Gynecomastia can occur, and testes are characteristically small, and there can be hypospadias or cryptorchidism, that is undescended testes. And the prevalence is 79 per 1,000 in intellectually subnormal population, and 10 to 20% in males attending infertility clinics. And it should be considered in patients with intellectual subnormality, behavioral problems, psychosocial problems, delayed puberty, gynecomastia, or male infertility. So this was one child with Klinefelter syndrome. So you may not get significant dysmorphism in all patients. However, a proper evaluation will give clues to the diagnosis. So in this, you can see the karyotype of Klinefelter syndrome. There is extra X chromosome, and the Y is also there. So it is XXY. So extra X is there. So chromosomal abnormalities in recurrent abortions, infertility, in especially first trimester abortions, you are likely to get disbalanced chromosomal translocations or sometimes inversions, and 3 to 5% patients you will get. In this abnormality is shown, that is 46XY inversion 9. The breakpoints are mentioned in the karyotype. And then if you do a chromosomal analysis in patients having more than 3 abortions, 3 spontaneous abortions, you are likely to get these chromosomal abnormalities. And in this was a 418 translocation. Chromosome 4 and chromosome 18 are involved as shown in the arrows. So these are the abnormalities that we have got in our RSA couples. So inversion of chromosome in chromosome 8, inversion in chromosome 7, translocation between 14 and 19, translocation between 6 and 18, and the chromosome 13 abnormality, that is when you have 213 chromosomes joined. So complex chromosomal rearrangement can also be seen in some rare cases of recurrent spontaneous abortions, and this can also lead to multiple pregnancy losses. You can see in the second one, there were 8 pregnancy losses, first trimester losses, and the complex chromosomal abnormality was identified between chromosome 1, 4 and 3 in the wife. So there can be also, we should remember, other causes of recurrent abortions like antiphospholylated antibody syndrome, protein S deficiency and factor V Leiden mutation when there are multiple abortions. And fish is a quite old technique, and still it has a role in detection of some of the abnormalities. It can be used also for detection of monosomies and trisomies. It is quite sensitive, and a shorter reporting time is there, so you get an early report. Even for antenatal cases also sometimes it can be used. And it can be used for prenatal diagnosis of Down syndrome and some microdeletion syndromes. So Prader-Willi syndrome is one of the microdeletion syndromes associated with genomic imprinting, and you can get obesity, short stature, intellectual disabilities, and you can identify chromosome 15 microdeletion in around 70% of the cases. These patients are more likely to get obstructive sleep apneas and acute gastric dilatation, which can cause significant morbidity in these patients. So there is a certain role of growth hormone therapy also in these patients. You can see two patients of Prader-Willi syndrome. One is an older child and one is a younger child. So you can either use fish or MS-MLPA for detection of this condition. So MLPA is a relatively recent technique that is multiplex ligation probe amplification, and this can be used to identify conditions like DiGeorge-Williams, Wolff-Rayet syndrome, and also some duplication syndromes. So this is the MLPA picture. You can see there is a blue line and a red line in the MLPA graph. You can see, and if it is above the blue line, it indicates a duplication. If it is below the dots or you can see this alleles, so you can find out. If it is below the red line, it indicates a deletion. So in the upper part, you can see there are 3 red dots, and that correspond to the gene names that have been given above, or probe names or gene names that have been given above. And in the lower part also you can see red dots below the red line, that indicates a longer deletion, and all the gene names have been mentioned there. So depending on which kit you are using and which region you have found this red or blue dots, accordingly you can identify which deletion duplication is there in that particular sample. So Williams syndrome, this was a 12-year-old boy presented with poor school performance, difficulty in performing activities like writing and holding pen and pencil properly. And in this actually you have also cardiac defect like supravalvular aortic stenosis, nephrocalcinosis problems are there. So though they are more social, and there is less of stranger anxiety in most of these patients. So this was a case of Wolff-Rayet syndrome. In that you get a prominent forehead and low set ears, and you can have dysmorphism which can give a clue to the diagnosis. This is the typical dysmorphism that you get Greek helmet or warrior helmet like this facial appearance. So this gives a clue to diagnosis of Wolff-Rayet syndrome. So this is one case. 3-year-old girl presenting with seizure and global developmental delay. The child had 3 episodes of seizures unprovoked, and global developmental delay was there involving all the sectors, and then there was history of myoclonic jerks. This was the child's the facial dysmorphism. You can see relatively large head with some facial dysmorphism. The anthropometry showed that the head circumference was at -2 z-score exactly. It was somewhat, it looks down like, but the head's size head circumference is maintained. She had coarse faces, short forehead, thick earlobes, hairy face, macrostomia, and hypopigmented nevi on the chest with clinodactyly. And chromosomal microarray was done, and which identified a 12p duplication, 3 copies of this region, which has been shown in the array result. You can see the copy number state is 3, and it is a gain. It is on chromosome 12. The cytoband region is also mentioned. The size of the duplication is also mentioned. The number of genes on that particular segment is also mentioned. and it has been identified as pathogenic. So we have a syndrome called Pallister-Killian syndrome, in which there is a tetrasomy of 12p, and in this there were 3 copies, and this was done from the blood. Sometimes you have to do from the skin biopsy to identify this Pallister-Killian syndrome. So one can have facial dysmorphism like coarse faces, full cheeks in Pallister-Killian, anteverted nostrils, postaxial polydactyly, ptosis, strabismus, myopia, cardiac defect like atrial septal defect or ventricular defect, diaphragmatic hernia, renal abnormalities like cystic kidneys, and intellectual disability with seizures would be there. So that is the severe phenotype of 12p duplication, and this leads to, when 4 copies are there, you get a early death. So this was another child who had shown a 9q34.3 deletion, and one can compare the area of the deletion with that found on the database of genomic variant or DGV, and in this again this CMA analysis was done to identify this deletion. This was the child which was on long follow-up. When the microarray was available, we did a microarray. Earlier we had done fish for DiGeorge syndrome, which was ruled out, and then when microarray came, we did from Sandor, and we identified this 9q34.3 deletion. So some few words on prenatal screening and diagnosis. Prenatal screening and diagnosis is mostly done for Down syndrome, and if already there is a previous Down syndrome child, or there is advanced maternal age more than 35 years, usually this prenatal screening or diagnosis is done. And one of the screening techniques is the quad screen or the quad test, in which 4 analytes are measured, including estriol, unconjugated estriol, beta HCG, alpha fetoprotein, and inhibin. And you can also have a dual screen or a combined screening when the patient or the couple comes early in the first trimester, and the combined screen is the best screening test. In addition, ultrasound can give clues to some of the markers like nuchal translucency, flat facial profile, duodenal atresia, cardiac defect, and then one can overall see what are the abnormalities present and do a confirmatory testing if essential. Suppose a screening test like quad screen or a combined screen come positive, usually a confirmatory testing is done, and which includes amniocentesis with karyotyping or fish or MLP or QF-PCR, whatever is indicated. So mostly for aneuploidies, one would do a karyotyping or a QF-PCR nowadays. And the new markers on ultrasound which can be identified include absence of the nasal bone, tricuspid regurgitation, and Doppler studies for the ductus venosus. So thank you everyone for your kind attention. So this is the book, the second edition of the book that was released in 2021. Dr. Haldar is also one of the editors for this. Thank you. Any questions? So now sir has come, sir can take over.
Thank you, ma'am. It was a very informative presentation, and thank you so much for providing us detailed clinical picture about various chromosomal anomalies. And now it's my privilege to introduce our next speaker. Our next speaker is Dr. Franny Shait. Presently, she is working as co-founder, director, and head of Cytogenetics and Molecular Cytogenetics, Fridge Institute of Human Genetics, Ahmedabad, and her research interest mainly on cytogenetics, molecular cytogenetics, and she has published more than 137 articles, 5 book chapters, editor of book on genetics in clinical practice, symptoms, diagnosis, and therapy. And her current research is on CMA in IUGR babies, neuropsychiatric disorders. So we welcome you, ma'am.
Good morning, everyone. Respected chairpersons and my dear friends and colleagues. At this outset, I would like to thank Dr. Neetu for inviting me and to our chairperson for a very nice introduction. Please excuse me if there is shaking in my voice. Yeah. Miscarriages are a frequently observed complication during pregnancies, and it is very challenging to the treating physician and couple when the repeated fetal losses are observed. 10 to 15% of all clinically recognized pregnancy result into spontaneous miscarriages, and half of the first trimester miscarriages are caused by fetal chromosomal abnormalities. There are various causes for repeated pregnancy loss, but I will be confined only to the chromosomal anomalies. There are two ways to detect the cause, especially for chromosomal disorder. One, to study the fetus. Second one, if the fetal tissue is not available, then by parental investigation. And we can get two information out of it. First one, if there is an abnormality in the fetus and parents are normal, we can say it is a de novo, only the fetus is affected and the recurrent risk in subsequent pregnancy would be comparatively less. But if the fetus has some chromosomal rearrangement and if it is inheriting from the either parent, then the recurrent risk depends upon the chromosome involved, the break site, and who is inheriting that chromosome. There are various techniques to use for genetic testing. The most common is a karyotyping, but when we are talking about a repeated fetal loss, then culture failure is one of the major problems we encounter. And to overcome that, the FISH is a technique which we can use it for certain numerical anomalies, like we can say chromosome 13, 18, 21 and sex chromosome that can scan around 80 to 85% of the numerical anomalies. The recent one is a microarray technique which has a good resolution, and if we use SNP probe together, it can also help to detect triploidy, tetraploidy, even uniparental disomy and even copy neutral alloH, which can help us. As said by the madam also, that karyotyping is a preliminary diagnostic investigation where we can detect both numerical and structural anomaly in a single assay, and that also microscopically visible. If we want to study any submicroscopic alteration, then we need to have a higher resolution, and there are two techniques. First technique is a FISH technique, where we can do two things simultaneously. One, that if we are talking about fetal loss and the chromosome is not possible, either the fetus is dead, and for karyotyping we need a live cell. In such cases, FISH would be helpful to rule out. Second thing, if there is any alteration and we would like to do the physical mapping, then on chromosome also we can do. Second one, in case of congenital anomaly where the karyotyping is normal, in such cases array CGH is very useful. In a single assay, we can study copy number variation in a form of a gain or loss. Second thing, it has a good resolution, we can say around 150 kb, and that can be increased to 10 to 20 kb if the coverage is increased to 1 million spots. Now here we can very clearly see this is just a comparison between FISH and microarray. When we are talking about FISH, the one of the most common we see is a Dajot syndrome. Commercially available, whatever probes are there, we can see there are 2 or 3 different sites they cover, which are normally commercially available. And here we can see there are 3 sites which are commercially available. But this technique is just like a keyhole technique, which will tell us only information pertaining to the probe we are using, will not give us any information even to the associated region. And for that, if we compare with the array CGH, we can see that whether there is a gain or a loss pertaining to a single chromosome, or if there are multiple chromosomes are involved, we can see it in a single assay. Second thing, we will know the chromosome number, we will know the exact size of it, and even the chromosome involved. Here we can see various chromosomal anomalies starting from, we can say, Turner syndrome to a trisomy of 22. We can see that there is a deletion of 16 and there is an inversion of chromosome Y, which is also called as a polymorphic variant, especially with the inversion Y. We can see triploidy, we can see tetraploidy, and here we can see that there is a triploidy. Along with that, we can see the structural rearrangement of chromosome number 3. So this shows that karyotyping can help us to detect both numerical as well as structural anomaly in a single assay, of course at the microscopic level. Here we can see that common numerical anomalies like 13, 16, 18, 21 sex chromosome can be detected by all three techniques. We can say that chromosomal fish and microarray. But the rare one, rare trisomy, cannot be detected by fish. But that can be detected very clearly with the help of cytogenetics as well as with array CGH. And more importantly, we can see that whatever structural anomalies which were missed because of resolution can be detected very precisely with the help of array CGH. So we can say that array CGH has a more power to detect submicroscopic alterations. We are going to a case based, and I feel that if we make it more as an interactive would be better. So if you have any query or if something is not understandable, please raise your hand. Here is a case where the couple had multiple miscarriages and one child expired at the age of 2 years. In such scenario, we always say that karyotyping is the best thing, and when we did karyotyping, we found that chromosome number 15 is having additional material. And to rule out this, there are two things. Either by array also we can detect it, and if we do not want to go for array as it is expensive, the second option is to go with parental karyotyping, because in around 80 to 85% cases, parents are the balanced carrier. So here we have done parental karyotyping, and in the parents we have seen that the father is having 315 translocation. So the derived chromosome 15 was shared by the father to the fetus, and that was the cause of miscarriage. And the recurrent risk in subsequent pregnancy is around 12%. Here in the second case, we see that there were 4 miscarriages, and second important thing we can notice is in all 4 cases there were unembryonic pregnancy. So no fetal tissue was analyzed. As I said earlier, the second option is to go with parental karyotyping. When we did parents, in the mother, strangely we found that the 4 chromosomes are involved. Of course, these are some of the rare things we see that involving more than 2 chromosomes in a single individual, but of course we can see such things. So we can see that complex rearrangement can also be detected by chromosomal analysis. Now in such cases, what will happen that if there is a miscarriage, fetal tissue is not available, we cannot process array in the parental sample, because parents will always have a balanced translocation. Array cannot detect balanced translocation, inversion, and insertions. So when we are going with parental study, karyotyping is the only technique which we can go for to rule out anomalies. And in the ideogram, we can see that how the chromosome has moved, and it can give us more precise information, right? And we can say that fetal loss, especially in this case, was due to chromosomal alteration in the fetus. Now, in the second case, we see that this couple had 2 miscarriages and in a Down syndrome child during 3rd pregnancy. Right, madam already said in a Down child we always see various patterns. And yes, it is very true. In around 80 to 85% cases we see free trisomy 21. In around 15 to 20, 10 to 15% cases we do see translocation Downs. Then the mosaic will also come. Here we can see in this case, specially 3 chromosomes are involved. Right? And when we did parents, we found that it was inheriting from the mother. Right? So in this case, if we do RACGH, it will tell us that child is having Down syndrome but will not give us any information pertaining to other chromosomes or even with the structural alteration in the fetus. So why we do all this investigation? To give precise counseling and the recurrent risk in the subsequent pregnancy. Now we know that the first child is having Down syndrome. Second thing, that the Down syndrome is in a form of a translocation. And it is inheriting from the mother. So the recurrent risk is high. What we can offer in a subsequent pregnancy? The most important thing is to go with karyotyping, because we can see everything together. We cannot give them NIPT because NIPT cannot detect those things, not even the array. Array can tell us if there is only imbalances are there. So in prenatal diagnosis, again the karyotype was carried out, and here also we have seen that same translocation has been observed like a mother. So they continued the pregnancy, and now the child is 5 years old, and this child is absolutely phenotypically and mentally normal. So structural rearrangement cannot be observed by RACGH. As per American Society of Reproductive Medicine, they always recommend that investigation to be carried out after 2 to 3 miscarriages. But nowadays we have seen that parents always want to know the cause, that what is the cause for miscarriage. And here we can see that was only a first trimester miscarriage, was a mother was a primary para. Still the investigation was carried out, and we observed that there was trisomy 22, and more precisely if we see the banding, we can see there was a paracentric inversion. Paracentric means where the centromere is not involved, and it was inheriting from the father. And here you can see the centromere is not involved, and the banding pattern, I don't think so, it is very well, but when we see under the microscope, it is very, very clear that the fetus was having trisomy as well as inversion. So what does this show? That father has shared 2 chromosomes, the inversion one also and the normal one also. So here the karyotype has helped to detect numerical and structural anomalies together. RACGH can detect if the trisomy is there, but not the balance inversion. In this case, we will see that fetus had cystic hygroma, increased knuckle translucency was there, hypoplastic nasal bone was there, and fetal demise at 12 weeks. So parents were so apprehensive. They say, I do not want to go only with karyotyping and not only with array. We would like to go with both the investigation. And we can see here it has given us such a wonderful information. With the karyotyping, we can see that there is a deletion on chromosome number 4. It has given us only one information, that is the deletion, because the chromosome 4 has become short. But with the help of microarray, we can see there is a deletion and a duplication both. So what has shown that chromosome 4 is the derived chromosome 4, where the part got deleted and a part of chromosome 5 has inserted into chromosome 5. So array can show us very clear picture here, even the deletion and duplication together, along with the precise break site. And here we can see that there was a 38 MB deletion on chromosome number 4. There was 22 MB duplication on chromosome number 5, and if the gene, any of the syndrome involved. And in the karyotype, when we did parental karyotype, we found that the father was a carrier. We can very clearly see that chromosome 5 short arm, that is upper arm, is enlarged, right? So in the fetus, only the chromosome 4, that is altered chromosome 4, was inherited. And if we precisely see, we can get even the recurrent risk in subsequent pregnancy. Now, if you study that chromosomal recurrent risk always varies, it is not the same like single gene disorder. When we are talking about single gene disorder, we can see that if it is inheriting in an autosomal recessive pattern, there is 25% risk. If it is dominant, it is 50% risk. But whenever we are talking about chromosome, the risk vary from conception till birth. So have to be very careful in mentioning everything in the report and the understanding of the report, that the recurrent risk, whatever they are telling, whether it is at term or it is during first trimester, because when the certain part of the genome is so sensitive that it will not allow the fetus to pass the first trimester, and that is one of the reasons why more number of chromosomal anomalies are detected during first trimester, spontaneous losses. Here in this child, during prenatal diagnosis, there was an increased and there was even the cardiac anomaly was there. Array technique was advised since it was a prenatal diagnosis. When we were processing the array assay, we found that the mother is having reciprocal translocation involving 8 and 13. And during this period, cardiac activity was stopped. And in the array, we found that there was a double gain. And since we are using SNP array, we can very clearly see that whenever gain is there, you will see 4 bands. Can you see it clearly, the 4 bands at both the places? That shows that it is a gain, right? So array also help us that not only gain or loss is there when the parents are carrier, it also detects that if the parents are carrier, this is also one of the things what we observed, that is double gain. Here the child had a cardiac anomalies, and we have seen that X chromosome is showing bit mosaicism. Can you, I don't know, I don't have anything, but I will try to do it here. Can you see here, this is the normal part where the X chromosome band should be there, but it's little lower, so we suspected there is a mosaicism involving chromosome X. And then we confirmed it with the help of fish, and we can see that in around 20% cases, monosomy X was there, and in around 75% cases, there was a normal XX pattern, and that was one of the reasons why the band, which we can see in a whole genome view, was a little on the lower part. Even array can detect if there is a triploidy. Here you can see that allele difference, we can see 4 allele difference, and that confirms that the fetus is having triploidy. The first band is of AAA, then AAB, then ABB, and BBB. This is how we can identify even triploidy, and if there is a single chromosome gain, can also be detected very precisely in a case of trisomy 9. So array can detect mosaicism, trisomy, and triploidy using SNP array, but we have to be very careful. It can detect mosaicism only if it is more than 20 to 25%, otherwise not. Here in a case, there were 2 miscarriages, and in both holoprosencephaly was detected, and during second pregnancy, increased NT was detected, and what we observed here was a gain on chromosome number 1, that is around, we can say, 11 MB, and there was a loss of 23 MB on chromosome number 13. So we thought that either parent is a carrier, and this case actually had come only for the confirmation of the parental status. So when we did a parental study, this is what we observed, that chromosome 1 is involved, and 1 is so critical that we found that not only the upper, that is P arm, but even the Q arm is also bit altered, which is extremely rare to see double break on a single chromosome, that also in a live patient. Here you can see there is chromosome number 6 is also altered, chromosome number 13 is also altered. Along with that, we have seen pericentric inversion of chromosome 9. So here this needs further characterization by Fish to confirm 2 break site on derived chromosome 1. We have seen the result of a last fetus, that there is only there is only a gain or loss involving chromosome 1 and 13. How come in the parents we are observing that chromosome 1 is there, but the site is not correlating? Second thing, that where the part of 6 has moved, because chromosome number 1, whole chromosome number 1, which is residing on the right hand side, is showing structural alteration. So this is what we have done, Fish. And in Fish, in first batch, we have used whole chromosome paint 1, whole chromosome paint 13, and 2 site-specific region. In the first one, we can see that the part of chromosome 1, that is in yellow color, had moved on chromosome 6 also, and chromosome 13 lower part also. Blue part, which is of chromosome 13, has moved on chromosome 1. And even the green part, which is the lower part of chromosome 13, has also moved to the chromosome 1 lower part. And in the second batch, we have seen that we have used whole chromosome paint 6, subtelomeric, that is the last probe which is possible of 1Q terminal region, and the subtelomeric 13Q region. See, every chromosome has a repetitive sequence. So when we say subtelomeric, that is the first probe, we can use it. And here also we can see that chromosome number 6 now, which is yellow in color, has moved on chromosome 1P. So overall we can see that derived chromosome 1 has a part of chromosome 6 also, and chromosome 13 also. So this chromosome is extremely rare, having 2 break sites. And here we can see that even the inversion 9 was being confirmed, that yes, there is a pericentric inversion of chromosome number 9. So now we always feel that analysis is one of the things, but how can we give the answer of array reports, right? So now we can see that the mother is a carrier involving chromosome 1, 6, and 13, right? And the mother is, with the help of Fish probe, we can say she is having apparently balanced translocation. Then why array CGS showed imbalance involving only chromosome 1 and 13 in the fetus? Now here we can see that mother has inherited only derived chromosome 13, and that is the reason for imbalance involving chromosome 1 and chromosome 13. And mostly the mother has inherited normal chromosome 1 and chromosome 13. Inversion 9 again is a polymorphic variant, and that cannot be detected by array, so we have no idea in the fetus. Pedigree is one of the very, very important thing to have a detailed history. And here we can see that in this family, there is a history of miscarriage from a parental side, and the patient came to us at the age of 30 years, and with primipara. And when this patient came, she said that her nephew had developmental delay and intellectual disability. And he was being investigated by RACGH, and there was 217 translocation, and the mother was investigated and she was the carrier of the 217 translocation. So the first and the most important thing is whether our proband, our patient who has come to us, she is a carrier or not. Now this was the report. Report was carried out at Emory Genetics, USA, and we can see that this was the report is. They have used indigenous fish probes, but there was no break site mentioned. So what important thing is that we have to identify the exact break point in the fetus. So using this backpack clones, we identified that there is a very tiny region which got translocated. Now when we see this terminal translocation on chromosome 2 and 17, it is extremely difficult to study at the chromosome level. So what we can offer? Karyotyping, or we can offer fish, or we can offer RACGH, or we can offer fish on chromosome. Now karyotyping, since the region is very tiny, it is submicroscopic, it won't give us any information. Fish. Alone fish will not give us any information. RACGH we cannot do because since the mother is phenotypically mentally normal, so there are all chances that either she would be normal or she would be having balance rearrangement. So the only technique what we can do is fish on chromosome. That is called as a physical mapping of a signal on the chromosome. Here you can see though the elongation is there, but we were not able to see anything on chromosome number 2 and chromosome number 17 with the help of fish using. Here also we have used whole chromosome paint and the subtelomeric 17q to identify, and we can very clearly see that the part of chromosome has moved to chromosome number 2. And similarly, in a second one where we have used subtelomeric 2 has also been moved on chromosome, subtelomeric 2 has also moved on chromosome number 17. So our proband is a carrier. She is a balanced carrier. Now the pregnancy has moved from 5 weeks to 12 weeks. This much time it has taken to confirm the carrier status in the mother. So the first fetal anomaly scan has shown that there was increased anti-single umbilical artery and small stomach size was seen. So in this case, there are high chances that fetal might be having some form of imbalance. So which technique we can offer? Fish or array? We had opted for RACGH, and here we can see that fetus was having 4.9 MB deletion on chromosome number 2 and 8.2 MB duplication on chromosome number 17. So this fetus is having imbalance, and that was one of the cause for a sonography marker to be observed during first trimester fetal scan. And ultimately, they went for termination of the pregnancy. Again, they planned the pregnancy, and again, RACGH was carried out, which was normal. Patient was not ready to undergo any further investigation to know the baby. It's a baby girl, and they were not ready to go under any investigation because the pain they were passing through. So they do not want to make the daughter to see that she is also a normal or a carrier. So no investigations are being carried out in a daughter, but either she will be carrier like mother or she will be absolutely normal like father. Now in the same family, the other sister came. And she was very much worried that my two sisters are a carrier, what would be my condition? She was just married, and the day she has married, she was under stress. So the same fish on chromosome technique was ordered, and here we can see that chromosome 2 is also intact and chromosome 17 is also intact. So this further confirmed that she is absolutely normal. No further investigation need to be carried out pertaining to chromosome number 2 and chromosome number 17. So for the take-home message, I can say that cytogenetics is a gold standard technique, can detect numerical and structural anomaly which are microscopically visible, and we can also detect marker chromosome. Marker chromosome is, we can say, just like a UFO, which can be originated from any part of the chromosome, but the limitation is we need a dividing cells. Fish can detect targeted region, and we have seen in my presentation also that it is very, very useful. But the most important thing, we should know the region of interest before we move further, because it gives information just like a keyhole. RACGH has really a great resolution, can detect CNV in a form of gain or loss throughout the genome, but remember, throughout the genome means only pertaining to euchromatic region, or we can say protein coding region only. It won't say anything pertaining to heterochromatic region or pertaining to satellite polymorphism. Can detect mosaicism provided the percentage is more than 25%. Uniparental disomy can also be detected and can also characterize supernumerary marker chromosome provided it should have euchromatic region. If the marker chromosome or a supernumerary marker, tiny marker chromosome is made up of heterochromatic region, cannot be detected by RACGH. Array don't need any dividing cells and cover, as I said, cover only euchromatic region. MLP and QFP-ACR are rarely used, especially I'm talking about repeated fetal loss. And thank you to my advisors, our team members, and special thanks to my collaborators who are from France and for Germany. They always help whenever I need. And thank you.
Thank you, ma'am. It was really a very scientific and informative presentation, and you have given the detailed picture about studies on chromosomal abnormality. Thank you so much. Now it's my privilege to introduce our next speaker, Dr. Ashutosh Haldar. So I want to introduce him. He is Professor and Head Department of Reproductive Biology, AIIMS, Delhi. And his research interest on reproductive endocrine disorders, infertility, disorder of sex development, malformation, reproductive cancers. And he has received many awards on Professor Mr. Maudgal Oration Award, then Dr. Subhash Mukherjee Oration Award, and he has been Fellow National Academy of Medical Sciences, Fellow Reproduction and Endocrinology, Fellow Indian Academy of Medical Science, Biomedical Sciences, and he has published more than 97 publications. So we welcome you.
Thank you. Good morning to all. And before beginning, sorry for coming late. And most difficult thing is that more or less similar topic and 4-5 speakers. If you are the first speaker, yes, you're done. But if you are in middle, it's mostly already done. So nothing is left for me. Anyway, I'll try my best. So the title which was given to me is by Dr. Neetu. Before starting, thank you Dr. Neetu and organizing committee for inviting me here, having me here. So application of fish and prints in clinics. So friends is a more or less dead subject. Still, I like to tell, invited to speak on this, but it's a very good technique and very cheap and rapid technique that I will tell. Fish is applications is much less, but it is not dead, and it will going to be forever because it has very specific role for characterization of things, which I will tell. Any pointer? So my presentation will cover principle of fish, means conventional fish, M fish, fire fish I am not going to speak on because these are more or less nowadays is more or less very rarely used except research purpose in cancer. CGH is a very good technique, very cheap technique, rapid technique, but difficult for karyotyping of DAPI banded chromosomes. That's why it's not popular and replaced by array CGH or SNP microarray and prints as you were asking for. And application of fish and prints in clinics. So first start with principle of fish. So it's a all molecular technique, the principle is same. DNA hybridization. So how to first DNA is a double stranded strand. You denature means separate them, then you renature, they again combine. But if you have some other leveled DNA which is also denatured, then some of them competitively can bind in a specific region of a strand DNA, test DNA, and you can see under microscope. So test DNA, here is a chromosome, double stranded DNA, you denature by separation, probe already denatured, and you combine this in a particular pH and temperature. So some of this level DNA will bind in specific area. Then you wash it non-specific binding and see under microscope, you will find your targets. And fish probes can be centromeric. If it is a centromere, then it may be telomere or subtelomere, it may be heterochromatic area, or it may be gene specific or locus specific. Or it may be paint probes. Just few minutes before you saw so many paint fish, see whole chromosome paint probes, or arm specific. You can have a P arm or Q arm specific. Or you can have a whole human genome as a probe, which is we used in CGH. So the principle of CGH is it's the same, DNA and DNA binding. And CGH or array CGH or whatever SNP CGH, the principle is the more the initial DNA, more will be the binding. So if you have a here, we have a test DNA, suppose it's a tumor or some malformation, the child DNA, one normal sex matched control DNA, and you label it, suppose green color, you label it red color, and if you mix 50-50 of these and hybridize on a metaphase spread, then what will happen? 50-50 red, if it is equal, no excess or less, then it will be a yellow color. Red, green, equal portion if you mix, it becomes yellow color. But if you have a green more, means some gain in the test, then that area will look greenish. And if you have a less in test DNA, you will get reddish. And this is a human COT1 DNA. Why we have used? Because in all genomes, there are many, every chromosome has a repeat sequence. And repeat sequence, that length is not equal. Even in pair of chromosomes, suppose chromosome 1, this area and another chromosome 1 pair, both of them may not be same. So it will bind disparately and fluorescence will be different. So that will hinder. Plus repeat sequence, what happens? Because of its repeated area, the hybridization will not be once, it is multiple times, and it will be very, very high fluorescence. So when you capture under microscope, and especially in CGH or array CGH or SNP array, that will glow so much that it will submerge other signals. So the rest of the signals will not be able to read. That's why you have to block repeat sequence. But instead of like here, this portion yellow, yellow, yellow means these are normal. This portion is green means test DNA is more here. And this is red means test DNA has deletion here. So this is the principle. And other principle is denature, renature. And in PCR you have a denaturation, annealing, extension. Here annealing and extension, whether it's fish or plains or CGH or array CGH, together. So denaturation is vast, annealing and extension more or less same, as we call it as a hybridization. If you instead of metaphase spread, if you put on DNA spots can be bacterial artificial chromosome, YAC, yeast artificial chromosome, PAC, phage artificial chromosome. Those are bigger, or oligos, smaller spots. Then we call it is a array CGH, and here you have to label both test DNA as well as control DNA. And exactly same way, some will be red, some will be green, and mostly will be yellow. And red means deletion, green means gain, and yellow means normal, euchromatic. But in another is here, this is called SNP array. Here we DNA spots mostly 2/3 or 3/4 will be SNP and some will be oligos. SNP means single nucleotide polymorphism, means each pair of, we have a pair of chromosome, one coming from father, one coming from father. They are different in some base pair. That's why it's, and it will be different signal length. And here we don't use control DNA. It's only test DNA, one color. And same principle, more the initial DNA of test will be more hybridization, less. And how we analyze it's more or less, it's a fluorescence intensity recording, and according to that will tell whether it's a gain or loss or equal. So it's only single test DNA, and this is the most advantage at this moment. Everybody prefers this. But at this moment, this array CGH is gold standard for all pre-implantation prenatal diagnosis. And this is still under, already we are using for diagnostic, but it's not yet recommended because it needs software some improvement. So principle already I said. So PRINCE means primed in situ leveling. Here also similar thing, only thing, leveling in fish we have a probe already leveled, and which is double standard, small pieces of DNA, double standard DNA, leveled with some fluorochrome. But here we don't use probe. Here this is like a PCR reaction on a cell on a slide. So either metaphase or interphase cells put on microscopic slide, then you do all pre-treatment. Then we use oligonucleotide primer specific for chromosomes, then simple nucleotides, all 4 nucleotides, plus 1 leveled nucleotide, and tag DNA polymerase and buffer. And we do the reaction. We denature together at 93 degrees centigrade for 3 minutes, anneal at 60 degrees centigrade for 10 minutes, and extension or elongation at 72 degrees centigrade for 15 minutes. One cycle or maybe more cycle, and to increase the signal strength. And stop the reaction by dipping into EDTA solution for 1 minute at 65 degrees centigrade. Wash excess of unbound probes and visualize under fluorescent microscope, and you will find your target. And most important thing is whole procedure takes less than 1 hour, and it's very, very cheap. Now application. So application will cover little bit on pre-implantation. That means embryo, gamete, polar body, prenatal, advanced maternal age, previous chromosomal abnormality, parents with carrier translocation, late suspected malformation on ultrasound. Here preferably we use array CGH or SNP array rather than conventional cytogenetics. And fish usually we try to avoid because most of the time the malformation which ultrasound gives may not be clear enough, so you may miss if you do fish, because fish is only for targeted things. Pregnancy loss, abnormal fetal death, preferably RACH or SNP array here also. Developmental anomaly, malformations, here also RACGH or SNP array is preferred. Postnatal, yes, there is real utility of application here, like ambiguous genital at birth, acutely sick infant with suspected chromosomal syndrome requiring immediate surgery or intensive care, like microdystrophin multiple malformation, methylation syndrome, infertility, oligozoospermia, suspected gonadal mosaicism, balanced translocation in male partners, etc., and cancer. Cancer still fish is indications are there. Diagnosis, prognosis, treatment monitoring, and follow-up. After microarray in the picture, the indications of fish has come down drastically, but still the advantage area is if you have a known translocation in the parents, then you can design your probe and you do fish targeted, and that will give quickest results. So that is still going on, whether it's a prenatal, it is a pre-implantation or postnatal, this is the indication. Then if you suspect mosaicism, fish is the best method. Then gametes, especially if you suspect gonadal mosaicism in male partners, you can do sperm fish and you can detect whether really mosaicism is there or not, but no other method will be able to give that precise quantification. Then known disorders in family screening. Some family has, suppose, Down syndrome or some microdystrophin syndrome, you can rapidly screen all the other family members whether they have or not, and rapid diagnosis when you require. Another thing is that for fish, normal metaphase fish must. Why? This gives this required to test the specificity and hybridization efficiency of the probe. Suppose you have not taken any control, you only done on test and you did not find any signal. You cannot say that it is failure of hybridization or deletion. So you have to have, but both the copy deletion will be very, very rare, but XY, that is another possibility. Then it should be always. Then another good thing is that you should always try to have more than one target fish. That also gives your sensitivity and specificity, as well as it gives you a confidence. Like this, here, 3 probes are used. Is a chromosome 15, centromere, parallel region, and PML region towards terminal Q. So all 3 means all 3 probes are there. So it's all 3 in 15 chromosomes, and all are working means, so you should be very happy that it's working perfectly. So multiple probes of same chromosomes will give confidence in reporting, especially if it is a interface fish. So first pre-implantation, this is a immature oocyte. How? This is germinal vesicle is still there. Then it's a mature oocytes, means first polar body is already extruded. Then there is a 2 or 3 cell stage embryo. Usually embryo biopsy we do after 6 cell stage. Nowadays, preferably blastocyst stage. So you can, at blastocyst, you can remove 3-4 blastomeres, and some you can go for fish, some you can go for PCR test. These are some of the pictures with pre-implantation fish. This is probably both the X chromosome probably. This is 19 chromosome, one has deletion, another has 2 copy. So PGD, pre-implantation genetic diagnosis, where at this moment it is fish is used coupled with translocation, means balanced translocation. And counseling is must, that for every pre-implantation genetic diagnosis should be followed by prenatal diagnosis, because in early embryonic life, the mosaicism is very high and anomaly is very high, and not all blastomeres will survive. Good one preferably will survive. So whatever you diagnose now or you miss now, you should be covered by prenatal diagnosis. Otherwise, problem medico-legal possible. So high chance for missing due to mosaicism. Fish here is a rapid and specific. And screening purpose, inclusion purpose, we don't do any more fish. It's a array CGH or SNP array or NGS method is preferred. Some of the pre-implantation genetic diagnosis here. Prenatal diagnosis, prenatal diagnosis is the most sensitive area in diagnostic service, because if you fail to diagnose some abnormality, chromosomal or microdeletion, baby will born with that abnormality, and party will take you into the court and you have to reimburse all expenses of the baby. So it is very, very tricky. And if you overdiagnose a thing, whereas baby is normal, you will be designated as a murderer. Means killing a innocent life. So one is moral, another is money. Both are involved. So it's the most sensitive part of any clinical practice, diagnostic practice. And means one wrong may cost a life, false positive, or may push you to the court, false negative. And rapid diagnosis, because usually most of the time ultrasound malformation occurs 16, 18 weeks. Previously our termination limit was 20 weeks, now it's 22 weeks, it's better. So in 2 weeks time, the conventional surgery itself will take 10-15 days. So there is hardly any time to react. And if your sample does not grow, then there is no enough time for second test. So it's a and that causes stress to the couple, means parents. So little time, in particular during second trimester, as termination may not be possible after 22 weeks of pregnancy. Or if you wish to have permission, then you have to go to court, you have to take special permission, if it is a very lethal malformation. No second sample generally available or possible in case of failure. So it's a very, very difficult one. And for prenatal diagnosis, you need invasive technique, first trimester, CVS. Rest early amniocentesis or coelomosynthesis is obsolete now. Second trimester, only amniocentesis, fetal blood sampling or fetal skin placental biopsy. Placental biopsy is done still in some cases, but fetal skin biopsy, others liver biopsy is obsolete nowadays because of molecular test is available. Previously we used to diagnose by histopathology, electron microscopy. Now it's not required. Now molecular diagnosis for most of the diseases are available. But I'm only talking about invasive technique, but non-invasive technique is also coming. That is called NIPD, not NIPT or PS. non-invasive prenatal diagnosis. Bayer's College is very advanced stage. What they are doing, they are isolating fetal erythroblast and fetal trophoblast, not exactly fetal, it's a placental trophoblast, by monoclonal antibody, HLA-G and some more, dual marker, and for erythroblast, epsilon gamma, one more marker, and they are enriching those cells from maternal blood and trying for diagnosis, and they are successful for many diagnoses, RHD, thalassemia, and they are going to come in 5-10 years time for the market. So for prenatal diagnosis, one should see this is a amniotic fluid after amniocentesis. It's clear. But this is same amniotic fluid after centrifugation. You see at the bottom red spot. What is red spot? It's nothing but maternal blood. So this you have to note. If it is any PCR related technique, then this might give you some confusing results, maybe some other bands. So if you are not aware of this, then you will not be able to report it. So if any cell concentration of 2% or more, that will be amplified. So be careful. But for fish, there will be no problem, because you know in amniotic fluid fetal cells are from fetal skin. Those are squamous cells. They have a different morphology. This is CVS also. In CVS also, there will be a lot of blood staining. You have to remove this. So thorough washing is must. And whatever the washing you do, there will be some cells of maternal origin. And your idea should be, before processing for any molecular test, that should be less than 2%. And you have to cut small pieces, then make single cell by collagenase, then slide prepared. What are these cells? These cells are amniocytes. These are just fetal skin squamous cells. See, big cells, irregular and very small nucleus. If you stain it, you will find like this. Small nucleus, big cells, small nucleus, big cells. These are squamous cells. So if your fish results restricts on these cells only, there will be no confusion. Always you will be right. But if you go and report on lymphocyte, neutrophil, then there will be problem. This is severe cells after spreading, and if you see, it's very good cells. Here probably there is no maternal cell visible in this field. Maternal cells, if somebody is, some cells is very round, most likely it's maternal contamination. Fish methods, principles I already said, there is no need for any. And these are some of the fish, 2 probe fish or 1 probe fish. These are all deployed normal. And if you have diagnostic service, you should have your own signal rate, what is from normal persons. You have to have your nomogram on your hand, probe specific, tissue specific. If it is a amniotic fluid, monosomy rate will be maybe 10%, trisomy maybe 1%, because in if it is CVS, it may be more, because they are aneuploidy, other things, chances is more, because in fetal cells is highly rapidly dividing cells, so error will be more, so those will be more. If it is an adult cell, it will be much less. In cancer, it's furthermore. So you have to have probe specific signal distribution, that in the hand, and then you make a mean or median and standard deviation, then take upper limit and lower limit for monosomy and trisomy. Then it will be always good. Otherwise, if any mistake, mosaicism diagnosis will be difficult if it is not gross. So prenatal diagnosis indications, specific carrier parents, NIPT positive fish you can do. High risk non-specific abnormal maternal serum biochemical screening. It is a trisomy 21 specific. You can go for Down syndrome. Ultrasound detector specific malformation, advanced maternal age, NIPT positive, etc. You can do. But at this moment, here we, especially malformation case, ADCGH or SNPRA is preferred. And American College of Medical Genetics and Genomics, they say that it's a very old, maybe 10 years old statement, that extremely high concordance between fish and standard cytogenetics when a diagnosis of aneuploidy of chromosome 13, 18, 21X and Y is suspected and still stands gold standard. But beyond that, not. So some of the cases, this is a prenatal. You see, what is this? Choroid plexus cyst. This is omphalocele and spina bifida also. So this combination usually indicates it's a trisomy 18. So we did QFPCR and fish, 3 signals. So it's a trisomy 18 with chromosome 18. And we terminated, see, spina bifida, omphalocele, choroid plexus cyst, we have to open up the brain, then only. Then another case, see, double bubble sign, stomach. Then the brachycephaly, small femur. So this also indicates trisomy 21. So we did trisomy 21 fish, and it is 3. So it is terminated, maybe terminated. This is a duodenal atresia, stomach and duodenum, both portion is dilated and strict duodenum atresia, plus sandal gap, wide gap between toe and first toe. Then ultrasound shows multiple cysts around neck, cystic hygroma, so monosomy X, we confirm monosomy X terminated. Then cystic placenta, severe IUGR. So cystic placenta with IUGR usually indicates what? Most likely triploidy. And we did fish XY, 2X, 1Y. X is green, Y is red, and chromosome 1, 3 copies, so it's a triploidy. Next is pregnancy wastage, anomorphic pregnancy or missed abortion. Here conventional cytogenetics is difficult, so fish or here also preferred method is ADCGH or SNPRA, missed abortion product. See here all the cells DNA is so moth-eaten, means very poor, disintegrated, so it's not good quality cell, so that's why culture mostly fails, that's why molecular techniques should be used. Legal malformation, some of the specific conditions we did, like this is a urorectal malformation complex where internal as well as external genitalia sex is not recognizable, and here we made sexing, and it is not a one sex, it's a XY as well as XX, so it's a gonadal dysgenetic syndrome. Then in pseudonomalia, even internally we won't find any pelvic structures, so here also sexing we did, it's a male XY. Then in severe limb body wall complex and OEIS syndrome where the sex was not recognizable even in autopsy, then we did sexing by fish. Then sometimes you see multiple malformation, fetus comes in a formalin, you can't do any conventional cytogenetics, and this abnormality means Indian anencephaly with cleft lip and telepesiculovirus, rocker bottom foot, indicates trisomy 13, and we did 13 fish, some are 2, some 1, so it's a mosaic trisomy 13. Postnatal, acutely sick newborn infant, suspected trisomy or CH, it's very important. You can do from nucleated blood cells, see all neutrophil, basophil, eosinophil, you can do. This is a trisomy, mostly 3 signals. You can do from mouthwash or mouth scrap. See, these are the bacteria. This is a good washing, no bacteria, but you can diagnose abnormality from mouth scrape or mouthwash. Even from urine cells you can. So for very newborn in ICU, you can take urine, you can take heel prick, or you can take scrap from the mouth, and you can do fish for your desired. Intersex is another important area where at birth is very important for rapid diagnosis, and fish has application. Labor room, baby born, is ambiguous. Grandparents asking boy or girl, boy or girl. Even parents also will ask continuously. You cannot delay much. If you delay after more than few hours, maybe 6-7 hours, it will broadcast everywhere in the locality. Something wrong. So it's a medical emergency, social emergency. So and stigma behind this. So you have to avoid this, and you have to have the ready where large number of birth is occurring. You should have a fish facility or QFPCR facility or even PRINCE facility, so that you in PRINCE you can give diagnosis in a 1 hour time. In fish you can give in 4 hours time. In QFPCR you also can give diagnosis in 4 hours time. So sexing, at least chromosomal sex is essential, because all your future management will depend upon chromosomal sex. So microdeletion syndrome, in microdeletion or multiple malfunction, see, my experience is for microdeletion syndrome, don't do fish, because our clinicians are not good in clinical diagnosis. They don't follow even whatever the criteria they have, maximum 60-70% success rate. So why you finally in 40-50% cases you have to do microarray? So why not first step as a microarray? So that will give beyond your suspected diagnosis and whole genome. So here I also we did so many times fish, but I don't recommend to do fish here. Here is a your 22q11.2 microdeletion, single cells, something. This is Prader-Willi. Here all signals are there. Here see proximal signals are missing. So it's a Prader-Willi region deleted, 15q11.2 deleted. Infertility, you can do sperm fish for sperm gonadal mosaicism, or oligospermia where recurrent IVF failure, that situation you can do. How many is cancer? In cancer still it is there. So you have to cut into small pieces, then you have to digest, then you have to do fish. And you will see cancer cells is so much, it's only XY fish, it's a female, so Y will not be there, only X. So many signals, some with 2, some with 6, 7. So it's a totally chaotic situation, not a single cell, means 2 cells are equal. Here also it's a breast cancer, it's so abnormal, means single fish, single probe fish. Here chromosome X in cervical cancer, breast cancer. Another thing is that you can follow up in cancer treatment, like here cervical cancer. Post radiotherapy 3 months, we took scrape from the cervical vaginal scrape, and we did fish. We found that a very big giant nucleus with abnormal signals. After 3 months of completion of radiotherapy, in another group we found small micronuclei with either normal or haploid signals, and we followed up these cases. This group we found a good prognosis, whereas other group we found mostly recurred in 6 months, 9 months. So you can, this can aid you in guiding next management before recurrence. Then these are oncogenes. Here also see, these cells no amplification, normal. Here some low amplification, low amplification, low amplification. Here HER2/neu, some are normal and some have low amplification. And this is c-MYC amplification in cervical. These cells have a huge amplification, maybe 1000 copy. Here no amplification, normal, 2. And if you do fish in this is a 4-probe fish, and so 5 to 8 copies of different um, probes means if you have 24 probes means what will be the situation? It's a totally chaotic situation. Cancer is a totally chaotic situation. This is only aneuploidy. Then amplification, here there is no all oncogenes. If some of the oncogenes may be amplified means 1,000 times, means you will mask everything. This is a M fish. See, in a solid cancer, breast cancer, how complex is this? Whatever madam was shown in a normal individual balanced translocation, here is all imbalanced. Such a complex 4 or 5 chromosomes involved in some chromosomes development, rearrangement. Hematological cancer, still it is there. One of the example is BCA-ABL, Philadelphia chromosome. This is a breakup fusion probe. Here chromosome 9, this portion ABL is broken, and this is a chromosome 22, this here portion here, and this portion fuses, which is called Philadelphia. So if two are together, it will be green, red and green. Combination will be yellow color, and if it is not break and fuse, then it will be separate, red and green. And if you see, normally you will find 2 green, 2 red, but if it is a fusion, 1 red green, which will be yellow color, and 1 red green. And here is this is the fusion Philadelphia chromosome. This is to normal 21 and 9. You can have, especially in hematological malignancy, multiple probes. So 20 probes, 20 times fish is too difficult. So now there is slides are available where all the leukemia, lymphoma, multiple myeloma specific probe panels is already plotted here. You have to put on cell, and in one go you can read everything. One go. CGH, RSCGH already principle we told. CGH, see, it's a very cheap. Probe is free. You are making your own probe, whole genome, and all information is given here. See, if more greenish means amplification, if reddish means deletion. So you can make karyotyping and you can read. See, this is a chromosome 8, semic amplification here. 6 also looks very greenish, means amplified. And if you see the profile, 8 highly amplified. This also gain the many losses, and some of the chromosomes like this. RSCG is SNP array. I'm not going to tell whatever already done case-wise. What we have seen that in 22, this is a very maybe 5 years old slide. We have now probably over 150 diagnosed microarray diagnosed 22q11. There, if I plot, it will be a huge one. See, not all have a classical deletion. Many deletions are very small, and no fish probe is covering these regions. So fish will miss these things. So microarray is must here. Similarly, in Prader-Willi syndrome, we have now 50 plus microarray positive this. Here also you'll find small atypical. Only thing in 5 prime, 3 prime area you are there, but not this area. So here also its dictum is never fish, always try for RSCGH microarray. Williams syndrome, here also you have 50 plus. I have not plotted everything, but in my anticipation at this moment is that here small atypical deletion we have not got yet. All classical big deletions. And microarray also will diagnose many unusual things. Like in this child, I think she is around 13 years old, had this kind of problems. Turned out to be triploidy, mosaic triploidy. And triploidy in live birth is not reported. And here mosaicism, even it's a quite substantial. Normal cell line maybe 25% rest is still is surviving, has mental retardation, short stature, scoliosis, vertebral, pelvic, thoracic abnormality, behavioral problem, hypotonia, flat, and rocker bottom foot. So this then retinoblastoma we did microarray and found not RV1 gene deleted, rather 13q31.3, 13q31.3, same locus in two patients we got, and which have GPC5 gene gain. So probably this is a newer information and causative of retinoblastoma we are getting. Prince is very fast. I told you the whole procedure in less than 1 hour. It's a pan-centromeric probe. Only problem is that the centromere, because of its heterochromatic area, repeat sequence, the amplification is not the same for each chromosome. Some may be bigger, some may be smaller, and that actually hampers capturing. Telomeric length also not same for each and every chromosome. Some are big, some are small, so you can miss some. This is a Y chromosome prints, and this is locus specific chromosome 21 centromeric pins and chromosome 13 centromeric pins, and it's very specific. You can, if one probe primer at a time, one target at a time, you can do for aneuploidy diagnosis with pins, and it's a very simple, very cheap, and very rapid. Thank you.
Thank you very much, Dr. Ashutosh Haldar. It was very wonderful presentation and elaborating. Thank you so much for elaborating different chromosomal abnormality diagnostic test. And now we move on to our next speaker, Dr. Shruti Agarwal, and it's my privilege to introduce her. She is presently working as assistant professor and senior scientist at Cytogenetics Laboratory, Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. And she has worked as postdoctoral research fellow, laboratory of Professor Lars Romstern, Sweden, and she is also as visiting researcher, University of Glasgow, United Kingdom, and she has worked as research assistant at National Institute of Immunology, New Delhi. And I welcome you, Madam.
Thank you very much, ma'am, for the kind introduction, and I'm extremely thankful to the organizing committee for giving me this opportunity. As Ashutosh sir said that already as a fourth speaker, most of the things are already covered, and especially by the experts from the cytogenetics field. But I will try to keep you all awake by covering some of the topics which have not been yet covered. So today I will talk about resolving the variations of uncertain significance which are found during a microarray analysis, and this is a great challenge. So as you have already heard, chromosomal microarray is we know is a boon with challenges. So when we subject samples to chromosomal microarray, which is a first standard tier test for individuals with autism, developmental delay, neurodevelopmental disorders, etc., and is recommended in fetuses with structurally abnormal ultrasounds. So many CNVs are obtained, and these CNVs are then subjected to genomic databases as mentioned here. And then we get three kinds of copy number variations which need to be classified either as pathogenic, benign, or a VOUS. So the pathogenic are reported as disease associated, and they have a diagnostic yield of about 6 to 16% over conventional karyotyping, and the benign ones are not reported. But the VOUS, that is the variations of uncertain clinical significance, remain a great challenge. and they do appear at a diagnostic yield of about 1.6 to 6%. So why is VOUS a great challenge? One, because these may have no relevance at all for the patient. They may later manifest as a disease, or they may always remain as a susceptibility loci. So the ACMG proposes a criteria for evaluation of constitutional CNVs based on a point-based scoring metric system. And ACMG and ClenGen consensusly have classified CNVs based on following evidence categories, such as the genomic content, dosage sensitivity predictions and curations, predicted functional effect, clinical overlap with patients, evidence from case control databases, and the inheritance patterns. So based on the scoring from all these evidence categories, the copy number variations are divided into either pathogenic, likely pathogenic, VOUS, likely benign, or a benign category. So as you can see here that the standard categories for ACMG classifications for both prenatal and postnatal setting was previously a 3-tiered version, and now it has been updated to a 5-tiered updated version, as you have heard before. The VOUS category has been subdivided into a likely benign and a likely pathogenic category. And however, they suggest that in a prenatal setting, a laboratory can choose to only report a pathogenic or a likely pathogenic variants associated with dominantly inherited conditions, but this should be well documented in the report. So what are the challenges associated with VOUS? Now, many a times practically we see that we get copy number variations from a CMA which do fit into reporting criteria very well, but have absent, limited, or conflicting associations with the clinical phenotype. Moreover, VOUS have a variable phenotype with extremely variable clinical outcomes. Many a times these are inherited from apparently normal individuals. And there is a great parental anxiety and a post-resulting genetic counseling dilemma. And particularly those CNVs that are associated with neurodevelopmental disorders pose a great challenge in reporting and genetic counseling, especially in a prenatal setting where they have a previously affected child. Subsequently, these VOUS may later be reclassified as benign or pathogenic variants as scientific data accumulates over time. So how to resolve? We must develop a collection or a repository of copy number variations in Indian population to determine the recurring VOUS on particular chromosomes with particular phenotypic spectrum. Wherever possible, do parental and family studies. This will help in a pre-test and a post-test genetic counseling. And follow-up is very important. So how do copy number variations arise? So we have copy number variations throughout the genome. But there are recurrent copy number variations existing at some of the chromosomes, which are flanked by repetitive DNA sequences known as segmental duplications or low copy repeats. They are present on many chromosomes, and few examples are 15, 16, 17 and 22q chromosomes. Here as an example, you see a 22q11.2 loci which has 8 LCRs A to H. So these high homology sequences, they mediate recurrent copy number changes via a non-allelic homologous recombination. Here you see the red and the blue arrows as paired LCRs, and when a recombination occurs between these, a deletion or a duplication arises. So these are copy number variations. So today I will present some of the cytogenetic data, microarray data from Sir Gangaram Hospital over last few years. So we have subjected over 3,500 cases to microarray, and today I will focus our data on recurrent copy number variations on 15q and 22q regions, and then finally compare the frequency of these VOUS with the pathogenic variants. So this is an example of copy number variations on 15q region. So 15q region is a hotspot for non-allelic homologous recombination, as mentioned before, due to presence of low copy repeats. As you can see, LCR 15.1, 15.2 and 15.3 are three regions of low copy repeats where recombination occurs, and on the left side you see a Giemsa stain chromosome 15. Further, this chromosomal region is highly regulated by methylation. The allele that is expressed for specific genes is based on the parent of origin. Presence of imprinting genes in this region further adds to the phenotypic consequence even in the absence of any of the genomic rearrangements. And this region is divided into breakpoints BP1 to BP5. A little bit more in detail, this structure here you can see a maternal allele MAC and a paternal allele. The whole region is divided into 5 breakpoints BP1 through BP5, and then you see genes which are green in color. These are the genes that are expressed biparentally. Then you have the blue ones, paternally expressed genes, the pink ones are maternally expressed genes, and the circles are the imprinting centers. When a deletion covers BP1 to BP3, this is called a type 1 deletion, which is 6 MB. And then when only 2 breakpoints BP2 to BP3 is covered, these are called type 2 deletions, and they are little smaller in size of 5.3 MB. So various diseases occur because of copy number variations in 15q1113 region. As you have heard before, Prader-Willi today already you have heard. I will take few seconds to explain. This is caused by the deletion of paternal copies of SNRPN gene and NDN, and in less than 1% it is caused because of imprinting center defect. This is again due to deletion of BP1 to BP3 region. And then we have Angelman syndrome, which is caused because of deletion of UBE3A maternal genes, and 70% of the times it is caused by a deletion of this gene, 25% because of mutation of this gene, 2% because of uniparental disomy, and 2 to 4% because of imprinting center defect. Now we have then 15q11.2 copy number variations, to which I will come later. The next ones are duplication 1511 Q1113 syndrome and the 15q13.3 deletion syndrome, which are present in BP1, BP3 region, and then the final one in the terminal region. So all of these, apart from 15q11.2, are disease causing regions, and it is very straightforward to explain the phenotype by the cytogenetic test. What I would discuss in detail is 15q11.2 region, which is having a conflicting data on the pathogenicity. Little bit more on this region. 4 genes are involved in copy number variations of BP1 and BP2. NEPA1, which is associated with spastic paraplegia. NEPA2 is a magnesium transporter. And then we have a cytoplasmic fragile X mental retardation interacting protein, and finally we have tubulin gamma complex associated protein. So each of these genes are associated with an important function. In a general population, this copy number variation occurs as a 0.3 to 0.6% frequency, and in the affected patient it may either occur as de novo or it can be inherited. It can be inherited from unaffected parents, and it can be inherited from affected parents. Each one of them have a frequency mentioned here. The point that it can be transmitted from unaffected carrier patients to parents to an affected child points to the incomplete penetrance and variable expressivity associated with BP1, BP2 copy number variations. So this shows the clinical picture of how these deletion duplications look on a microarray. So we have a total of 42 patients showing varying degrees of this copy number variation. In figure 1, you see a BP1, BP2 deletion with a marked with an arrow. Then you see a typical deletion associated with either Prader-Willi or an Angelman syndrome, BP1 to BP3 deletion, which we mentioned as type 1 deletion, and then you see a BP1, BP2 duplication marked by arrow below the blue amplification. So this is a positive case of an SNRPN deletion. The first child was affected, parents were normal, and the child had developmental delay, stereotype hand movements, seizures, characteristic laughter, and jerky movements. So when the sample was subjected to chromosomal microarray, here we clearly saw the deletion of BP1, BP3 region comprising of SNRPN and UBE3A important genes, and FISH confirmed this deletion. As you can see, only one single signal corresponding to this region. So during the prenatal analysis, amniotic fluid was subjected to karyotyping and FISH, and there we didn't see any deletion. So the fetus was absolutely normal. So a number of pathogenic copy number variations were obtained in this region. Most of the patients had phenotypes of global developmental delay, neurodegenerative disorders, global developmental delay, dysmorphism, etc. And the prenatal sample had increased NT and or a POC with a missed abortion. In most of them, we see either BP1, BP3 duplication, or a BP4 to BP5 deletion. So then we had certain samples where we saw 15q duplications in the CMA, and most of the patients had either developmental delay or there was NT increase, absent nasal bone in prenatal, and this was confirmed by a FISH and karyotype that there was a presence of marker in these samples, which was showing as a duplication in chromosomal microarray. Not all the markers were pathogenic, some were benign depending upon the genes contained in this copy number variation. So this is how it looks in the cytogenetic techniques. In chromosomal microarray there was a big 12 MB duplication. This was confirmed by FISH and also by the karyotype, where you see a supernumerary marker chromosome derivative 15. Now the challenge was to see that there were number of variations of uncertain significance in this region. Here we see the samples in postnatal cases. Majority of them had clinical indications similar to the positive cases, such as global developmental delay, microcephaly, obesity, autism spectrum disorder, etc. And most of them had a copy number variation at BP1 and BP2 region. These are the cases in prenatal category. Again, they had either anti-increased echogenic focus in the left ventricle, lower urinary tract obstruction, or mild polyhydramnios, etc. And these also had copy number variations containing the 4 genes that we discussed before. So this is how the distribution of cases in BP1, BP5 region. So the N was equal to 42, and I don't know where this picture, this was actually a breakpoint analysis. Different breakpoints were present in this category, and so the 67%, the majority of cases belong to BP1 to BP2 category, which are variations of uncertain significance. So more than half of the CNVs of this region belong to VOUS. So these are the few cases that were represented in this region, just to see where the overlap of copy number variation occurs. And we see that majority of the cases belong to either BP1, BP3 or BP1, BP2 region. So BP1, BP3 copy number variations are clearly pathogenic, and so reporting and both genetic counseling are straightforward. The counseling dilemma lies in the BP1, BP2 copy number variations. So this was about 15q. Now I will talk about a little bit on the 22q regions, why this region is challenging. Again, because of the same reason, that there is a presence of low copy repeats by which meiotic non-allelic homologous recombination occurs and gives rise to recurrent copy number variations. This is the genetic architecture of 22q. Here we have either proximal DeGeorge deletion comprising of the important clinically significant HERA, TBX and COMP genes. Complementary to this, we have 22q11.2 duplication, which is of the same region. Then we have central deletions of this region where the candidate gene is CRKL, distal deletions where the candidate genes are MAP kinase ERK2, and then we have the terminal Fallon-McDermott deletion comprising of ARSA and SHANK3. The genes in the green bars are the ones which categorize these CNVs into a VOUS, and the blue ones still have a conflicting data. At one point of time they were suggested to be benign copy number variations, but now more and more studies are pouring in which classify them, which arise this conflicting data that they can also be disease causing. So the common pathogenic CNVs in this 22q region are: number one, the first picture is 22q DiGeorge syndrome deletion. The next one is a 22q11.2 microduplication syndrome. The third one is the distal 22q11.2, and finally we have Phelan-McDermid syndrome. Now this is a positive case for DiGeorge deletion. This adult person came for a preconceptional counseling with mild developmental delay, inguinal hernia, bilateral corrected CTEV and hypernasal speech, and his sample was subjected to CMA and FISH, and the deletion was confirmed by both techniques. And the classical phenotype you all may be knowing of DiGeorge is cardiac defect, facial dysmorphism, thymic hypoplasia, umbilical hernia, mild to moderate learning difficulties, which kind of fitted into his clinical phenotype. So this is the distribution of our cases in this region. So you see that there are the n is equal to 30 samples, and we have deep red bars which indicate the pathogenic copy number variations. These had phenotypes of congenital heart disease, intracardiac echogenic focus, IUGR, anti-increase, global developmental delay, and so on. And then we have Phelan-McDermid deletions with global developmental delay and congenital heart disease at the 22q13 cytoband. But apart from these clearly clinically significant copy number variations, we had a large number of copy number variations represented by blue bars here, which fall under the category of uncertain significance. So here you see that that when we compare the copy number variations of VOUS between 15q and 22q region, here you see that pathogenic CNVs are the VOUS is almost double than the pathogenic CNVs, clearly showing the burden of VOUS that we have in the clinical samples. So what is the conclusion? These are the two of the most variable regions in the genome. Associated phenotype may depend on the context of additional alterations or a second hit, and whether they may be related to a physiological pathway. As reflected by unaffected carrier patients in some studies, these CNVs may or may not be sufficient for a phenotype. Large cohort studies underline the significance of 15q and 22q regions as a definite susceptibility loci for neuropsychiatric or neurodevelopmental disorders. So these patients may not be actually suffering from the disease, but they do carry a susceptibility loci, which may or may not manifest into a disease. So therefore, careful clinical evaluation of proband and parents is warranted, as the reported CNVs have incomplete penetrance because they are not always inherited, variable expressivity, they can have a wide phenotypic spectra. So how does literature report about these copy number variations? It's a great reporting dilemma in both postnatal and prenatal settings. So following are the few studies, there are many studies, but I have cited only few of them here, that there are some people referred it to as a high frequency low penetrance copy number variant because it has pathogenicity of only mild effect size. It explains only a small proportion of phenotypic variance in carriers. Then there was another article by Maya et al, and there was a question raised, should we at all report these 15q11.2 BP1 BP2 deletion and duplication, especially in the prenatal setting, because it has low pathogenicity and minimally increased risk for abnormal phenotypes. So can we just opt out of reporting these CNVs so that it is convenient to both clinicians and the couples? And then there was another article in Nature which said that CNVs conferring risk of autism or schizophrenia affect cognition in controls. So then we had similarly we had articles for the VOUS on 22q region, that this region also with the genes which are clearly not clinically significant, presence of genetic variation in these genes present an unusual pattern and increases the susceptibility to schizophrenia. Then we have from 22q12 region that these genes are responsible for increasing the risk of ASD. And then recently we had an article where these CNVs which we used to report as benign copy number variations were present in children with respiratory syndromes, and therefore they have now they mentioned these copy number variations under variations of uncertain clinical significance. So so this is a great dilemma. And what is the future perspective? The purpose of this study was to describe the prevalence and counseling dilemmas regarding VOUS associated with low penetrance and variable expressivity, to emphasize on strengthening the databases on recurrent copy number variations that arise due to low copy repeats and a susceptibility loci. Because if we just opt out of reporting these VOUS, they will never get resolved. And who knows that as the scientific data accumulates over time, these can be reclassified as pathogenic or likely pathogenic or maybe even benign. So we don't want to be in a situation where the copy number variation was present, we give a normal report, and in the next generations something more precise comes and they say that okay, this copy number variation is present, was it inherited or was it a de novo? So we think that we must report any variation that meets the reporting criteria and has at least some relevance. And it is very important to follow up the carriers of these CNVs to establish the etiology. Once the outcome is analyzed, as I said, it may be recategorized, and this will give a significant confidence to both the clinician and to the patient. Keeping all above in mind, a pre-test and post-test counseling is very important and should be done only by well-trained geneticists, because they would say that okay, this copy number variation, there is a risk in your genome, but how smooth the road ahead is. So it is very important that the post-test genetic counseling is done by trained geneticists. With this, I would like to acknowledge our cytogenetics team, the whole Institute of Medical Genetics and Genomics at Sir Gangaram Hospital. Dr. I.C. Verma was recently awarded as Padma Shri for his countless efforts in the field of genetics. Dr. Ratna Puri, who is the chairperson of our department, and Dr. Meena Lal, who is the head of Cytogenetics lab. And I thank you all. I'm sure that each one of us in the audience can associate with one of these stages of genetic research cycle, and together we should all keep the genetics research cycle moving. Thank you very much.
So thank you, Dr. Shruti Agarwal, for updating us about the recent ACMG guidelines and also for providing us pathogenic pictures of different syndromes. And now I invite our next speaker, Dr. Amita Pandey. She is Professor, Department of Obstetric and Gynecology, King George's Medical University, Lucknow. And she has published more than 100 research publications in national and international journals. And her area of special interest on genetics, infertility, endocrinology. So welcome, Dr. Amita Pandey.
Very good afternoon to all of you. Since today morning, we've been hearing going through wonderful presentations, discussing the details and the nitty-gritty of the high-tech genetic tests that are available and how these tests are able to help the masses, help the patients, help the doctor come to a particular diagnosis, and then subsequently appropriate management can be offered. But my topic is something which is, I think, more for the general population and for the students. Because we all know that genetics has a very important role to play in all fields of medical science. I am an obstetrician and I am a geneticist, so I would be trying to highlight the role of genetics in modern obstetrics. Because just as I am highlighting the role of genetics in obstetrics, similarly, it goes in all the various departments and branches of medical science. So this is more for the medical students who are here to understand how we can apply this knowledge. This is a very basic lecture, but you will realize how we can use the details of the knowledge that we've been hearing since morning in our day-to-day clinical practice. Now, can anybody tell me why the year 2003 was a landmark year as far as genetics is concerned? Anybody? We have so many students here. Or anybody? Anybody would like to try? No student? That was the year when the Human Genome Project was completed. And once that was completed, it opened the gateway to a spectacular progress in clinical genetics. Because only then we were able to develop these tests that we have been discussing since morning today and come to conclusions and diagnosis as we've been discussing. So I would again highlight that genetics plays a very, very important role in virtually all disorders, be it in its causation, its predisposition, susceptibility, management, whatever. And the most dreadful thing to share is that each of us carry at least 20 harmful genes. So who knows, subsequently, we would, like as Dr. Has just highlighted before me, that the VOUS may sometime later on be labeled as pathological. So similarly, who knows, we would be able to decipher these genes and then come to the conclusion whether it is harmful or it is not. Now, as far as obstetrics is concerned, we all know that having a perfect baby is everyone's dream. And unfulfilled dreams may be very, very traumatic for the entire family. And this is a spectrum of disorders that we as obstetricians get to see in our day-to-day life. If you go just across the road to our department, you will, any single day, you will be able to see 1 or 2 women delivering such babies. And if we look at the obstetric load, we can see that it is enormous. Almost 10% of all conceptuses have a chromosomal abnormality. 50% of all first trimester abortions have chromosomal abnormalities. 0.2% of all babies are born with balanced chromosomal rearrangements. And 5% and 12% of stillbirths and neonatal deaths are associated with some defects. And 3 to 4% of all births are associated with major congenital malformations. So I'm sure you would agree with me that no scientific field has a greater impact of genetics on clinical practice than obstetrics. And hence a very basic knowledge of genetics is very, very essential in modern obstetrics. Genetic counseling, as we've been hearing since morning, is a very important part of the field, the specialty of genetics. And now in obstetrics also there is a need for genetic counseling in almost all pregnant women. Because if we go just look at this list, this is such a long list which shows the indications of genetic counseling in obstetrics. Every day, nowadays, we get mothers with advanced maternal age. We get mothers who come with reports of abnormal maternal serum screening test result, or they come with reports of abnormal finding on ultrasound evaluation during pregnancy, or they come with a family history of some genetic disorder or mental retardation, or they come with a history of a previous child or a fetus with some genetic disorder, or they themselves have diabetes or epilepsy, they are on certain drugs whereby they are at an increased risk of fetal congenital malformation. Or they say that they have had some exposure to teratogens. It could be some drug, it could be some disease. Like very frequently in this season we are getting mothers who have had chicken pox in early pregnancy and they come running to us. Mothers who have varicella who come running to us, or mothers who have, pregnant mothers who have accidentally taken some rubella vaccine and they come running to us. So these are the places where we need to give them genetic counseling. Then geoethnic carriers of harmful genes are well known. Consanguinity, especially amongst the Muslim population, is very, very rampant, and genetic counseling is an essential part over there. Then there are women who come to us with bad obstetric history, and as we have been discussing, before population screening, before any prenatal screening, before any prenatal diagnosis, after these diagnoses, to explain the results, we need genetic counseling, and for every small thing, the patient cannot rush to a geneticist, and that is why the emphasis is on a basic running knowledge of genetic counseling for all obstetricians. And this counseling, we all must be trained to give non-directive and non-biased counseling. Nowadays, a lot of prenatal diagnosis facility is there everywhere. In fact, there are companies which are offering these diagnostic tests on the internet. So, and the patient comes to doctors, and the companies also go to the doctors, and they convince them that everybody should advise all tests to everybody and go for stem cell banking. So these are the places where I think obstetricians need to have a basic knowledge of genetics, and with the availability of these prenatal diagnostic tests, one must be able to estimate risk, because nowadays there is a lot of emphasis on risk of recurrence with the availability of prenatal diagnosis. So we need to counsel patients regarding the risk of a particular disorder. And here I will just share a story. Many of us are from Sanjay Gandhi Postgraduate Institute. So I'm just sharing a very old story. When we were students, there was a mother who had come with a thalassemic child, and she had sued a very famous obstetrician of this city. Dr. Haldar was talking about the medico-legal liability that is there if you diagnose things aberrantly. I am sharing the medico-legal liability if the obstetrician is not able to pass on information about the prenatal diagnosis that is available. This is the story of 1980s, when genetic tests were just getting very common. And unfortunately, the obstetrician had not counseled the parents about the risk of thalassemia in their child. They had not done thalassemia screening in that child. See, I'm talking about 40 years back. And the couple had sued the doctor. Why they had not counseled. So that is why the emphasis is that a working knowledge of genetics is very, very essential for all of us. Whatever field of medicine we are working in, we all need to be aware of these things. And as obstetrician, the importance of this knowledge is much more, because we need to counsel pregnant patients. We need to pick up things about the risk of genetic disorder in a couple. We need to counsel them about risk of recurrence when the baby is born. We need to counsel them about the availability of prenatal diagnostic techniques. Similarly, nowadays everybody is warming up to the concept of preconception counseling and screening, which we all know is the best time for genetic counseling in obstetrics. Here again, the basic knowledge of genetics is very, very important for obstetricians, because that is the place where couples usually go to for any preconception counseling and screening. Population screening carrier testing, that is also very common, especially in India. We are having population screening and carrier testing for thalassemia, sickle cell anemia. So we have to counsel the couple about reproductive alternatives, like the availability of prenatal diagnosis, deferral of childbearing, at times even artificial insemination. So ideally it has to be done preconceptionally, but the knowledge about all this should be there with the obstetrician. Maternal serum screening during pregnancy is very, very common and is available all over India. Low risk, high risk, everybody is being offered maternal serum screening. So how to interpret those results is very, very important for all obstetricians. There are so many types of tests available, the plain double markers, the quadruple test, the stepwise sequential test, the integrated screening. So knowledge of all this is important if you are in the field of obstetrics. How further refinement of this can be done? Then similarly, the government, we all know that not only the American guidelines, not only the UK guidelines, not only the WHO guidelines, even our Indian guidelines have put down 3 basic ultrasounds in any pregnancy. चाहे वो patient PHC पे deliver हो रही है, this is there in the Government of India, Ministry of Health and Family Welfare guidelines. So we all need to know that every woman has to have a targeted scan for fetal anomalies from 18 to 20 weeks, because all pregnant women have a risk of 3 to 4% risk of having congenital malformation in the fetus. And routine screening by this scan can lead to a detection rate as high as 50 to 75% of major congenital malformations. Then soft markers for fetal aneuploidy. We need our radiologist friends are picking up these soft markers, but how to interpret them? We have had instances when pregnancies have been terminated because an echogenic cardiac focus was present, and it is such a shame because some obstetrician was not able to interpret it properly. So that is why a basic knowledge is very, very important. We do get to see choroid plexus cyst. We do get to see renal pylectasis. But what to do in these cases is very, very important, because for each and everything, the patient cannot be referred to a geneticist. Prenatal diagnosis, as we have seen, is very rampantly available. And maternal serum screening is being done for every patient. But patients are not being counseled before these tests are offered. They are not told that these are just screening tests, and they have to undergo a confirmatory test, which is an invasive test. So all this knowledge has to be there with the obstetrician. The obstetrician must counsel the couple about the risk associated with prenatal diagnostic procedures, the limitations, the implications, the reproductive options before offering the test. Otherwise, what happens? The maternal serum screening is prescribed, they come with a report, and then they said, हमें तो कभी करवाना नहीं, this is an IVF pregnancy, मुझे तो कोई test ही नहीं करवाना है. So all this should be done before advising these tests. NIPT is becoming very, very common, and it has become very cheap also. So every patient is being offered NIPT, and the patients think that that is the final diagnostic test to rule out all forms of disorders in the children. So this again should be, this is very important for obstetrician to counsel that this is just a screening test. Even if the NIPT is positive, she will need a confirmatory test, come what may. PGD or many IVF labs in India, they are just offering pre-implantation genetic diagnosis without counseling the patients about the limitations of the technique, the risk of error, and the ethical implications. So this knowledge also has to be there for the obstetrician. Fetal autopsy is never being advised. If you look into obstetric practice, there are so many babies that are born with congenital malformations, not even a picture is clicked, not an X-ray is taken, and the babies are discarded. Or there are stillbirths. Nobody is bothered about those stillbirths. Obstetricians need to ensure that at least a good picture in an AP and lateral view is taken. A skyogram is at least taken of that baby, and a wholehearted counseling must be done for the patients, to the couple, so that they go for fetal autopsy. I have heard patients saying that मुझे डॉक्टर ने बताया था कि बच्चे की चीड़-फाड़ की जांच करनी है, मैं चीड़-फाड़ नहीं कराना चाहती थी. It shouldn't be counseled that way. It has to be counseled with a story, with the implications. So for that, we need to be convinced first that how important fetal autopsy is when we need to give a proper risk of recurrence. For example, here in this picture, you can see a fetal autopsy has been done. This baby presented with occipital encephalocele, and the baby was being just discarded. The fetus was aborted because the fetus had an occipital encephalocele. But on fetal autopsy, it was found that the baby also had bilaterally enlarged kidneys and polydactyly also. So the risk of recurrence changed from 5%, which is given for empirically for occipital encephaloceles, to 25% risk in the next baby with this diagnosis. So that is very important, that proper counseling should be there, and for this again obstetricians are responsible. So that is why we need to ensure that in all fields doctors must be aware of the latest advancements in the field of genetics and must counsel appropriately, because we live in an era of medico-legal liability. We need to be aware of what is going on. We have to tell everything to the patients. We have to keep counseling them properly. The art of counseling should also be taught at the MBBS level. And as far as the field of obstetrics is concerned, obstetricians play a key role in reducing the load of hereditary diseases in the community. That is why optimal knowledge of genetics enables them to offer appropriate and informed care. And genetic counseling, the art of that counseling is very, very important. Thank you very much for your patient hearing.
Thank you, ma'am. It was indeed an enriching experience to attend such an informative and intriguing session. Every element and every talk enlightened us on this new and emerging field. It is not joy that makes us grateful. It is gratitude that makes us joyful. I would like to express my sincere gratitude to our respected chairpersons, Dr. Anuradha Nishal ma'am and Dr. Reema Kumari ma'am, for gracing the occasion. I am also thankful to our eminent speakers for the day, Dr. Ashutosh Haldar sir, Dr. Freni Sheth ma'am, Dr. Amita Pandey ma'am, Dr. Shruti Agarwal ma'am, and Dr. Inusha Panigrihi ma'am, for sparing their precious time to share their knowledge through such intriguing talks. I am also thankful to our participants, attendees, and audience for their enthusiasm. The memories of this session will definitely remain etched in our hearts forever. We thus present our honorable delegates with mementos as tokens of our reverence for them. I request Dr. Neetu Nigam ma'am to kindly present the memento to Dr. Reema ma'am, who has been the honorable chairperson for the session. Ma'am, please. Thank you, ma'am. I now humbly request Professor Arundhati Sharma ma'am to kindly present the memento to our honorable speaker, Professor Amita Pandey ma'am. Ma'am, please. Thank you, ma'am. I also request Professor Arundhati ma'am to kindly present the memento to Dr. Ashutosh Haldar sir. Thank you, sir and ma'am. I now request Professor Reema Kumari ma'am to kindly give away the memento to Dr. Inusha Panigrahi ma'am. Ma'am, please. Thank you, ma'am. I now request Professor Rajni Gupta ma'am to kindly honor our speaker for the day, Dr. Frenny Sheth ma'am, with the memento. Thank you, ma'am. I request Professor Rajni Gupta ma'am to kindly present the memento to Dr. Shruti Agarwal ma'am. Thank you, ma'am. With this, we come to the end of the scientific session 1. I would now like to request our delegates and attendees to kindly proceed to room number 106 on the ground floor for lunch. The poster presentation will take place during the lunch break. We request you to kindly assess the posters and acquire knowledge from these informative presentations put up by the participants. The scientific session 2 will commence at 2 p.m. following the lunch break. I request all to kindly assemble at the same venue for post-lunch. Thank you, everyone.
Oh, hi. Hello, Neetu. I can't make any presentation. I don't know what's going on. Huh? Have you saved what? Yeah, I'm looking at the screen, the Google Meet, and there's no link how to link my presentation. I never used the Google Meet. I told you that मैम इसीलिए मैंने आपको अपना भेजा था आप it's a waste of time because I'm wasting for half an hour sitting on the computer and I send my link to you. You say when I present now, but there is no how to link that.
Dr. Nitin Nigam.
Hello.
Hello.
Yeah.
Sir, can you log out from this? We have shared your Zoom link.
Hello, good morning from UK. Hello, good morning. Good afternoon to all of you. Thank you very much for inviting me. Dr. Dini Nikam has worked very hard for this workshop. The topic I have been given is really an overview of the cytogenetic contribution technology and further few developments. So I have nothing to declare, no conflict of interest. And I acknowledge many of my colleagues who have contributed to my books. And some of the material appears in the presentation. So we have to really acknowledge and dedicate to previous innovators, researchers in this field, namely Watson Crick, who discovered double helix, Geo, who was the first person to confirm the chromosome number in man, and of course, Hargobind Khurana, who cracked the genetic code. So these three and many other discoveries laid the foundation what we call today modern genomics or genomic medicine. So as you know that there are many different groups of genetic diseases, chromosomal, Mendelian, multifactorial, polygenic, mitochondrial, epigenetic. For each group, we have got designated technology now in action. Most modern genetic laboratories use these technologies as required. And so it is, although we started from cytogenetics, but we have made a huge progress over the years. If you look at the landscape of the whole genetics, the center, the cornerstone remains the karyotype, the cytogenetic, as you can see from this male karyotype. So clinical diagnosis, and then the management along with our colleagues, and it has helped disease mapping. Many candidate genes have been localized because of cytogenetic changes, gene mapping, gene cloning, and right up to the prevention, what we are practicing today. So starting from aneuploidies, as you can see from these three classic conditions, trisomy 21, monosomy 45, and then extra X in the Klinefelter syndrome. So these aneuploidies indicated the whole genomic element. They are related to one single chromosome or extra, whether it is extra or missing that homologue. In this slide, we'll see highlighted areas which are all cancers. So aneuploidies was the first indication of the genetic basis of cancer, starting from these three selected aneuploidies. Then we moved on, we found many structural changes in chromosomes, deletion or duplications, and inversions and ring chromosomes, and many other structural changes. Some of these were de novo, and some of them were resulting from the reciprocal or Robertsonian chromosome rearrangements. In this slide, you can see practically every chromosome with a small area, whether it is short arm or long arm, either missing or additional segment present, and which manifested in distinct syndromes, what we call microdeletion, microduplication syndromes. These were the beginning of a very important concept in genetics called non-allelic homologous recombination. As you can see from this slide, deletion, duplication, inversions, and then this is a very classic presentation how chromosomes during meiosis, meiosis stage number 1 or maybe stage number 2 get together, and because of being the non-allelic homologous recombination result in the deletion or duplication. The classic example is the Williams-Bjorn syndrome, which is related to 7q deletion, as you can see from this slide. And apart from the classic phase, classic behavior pattern, cognitive abnormalities, there was very striking congenital heart disease called supravalvular aortic stenosis. What happens, as you can see from this segment, there is a gene called elastin, ELN, along with many other genes missing in this 1.5 megabase segment. And that elastin gene is very important for connective tissue, especially the middle part of the aortic, early part of the aorta, or just above the aortic wall on the left side of the heart. And these children, they require open heart surgery in most cases. So the reason why there was a deletion in this segment, again, because of repeats, and again, because of recombination, and then deletion occurred. And many genes, so this is also called the contiguous gene syndrome, a classic example that was the beginning of the whole branch of cytogenetics. Then we also found overgrowth syndromes like Beckwith-Mardeman syndrome. Initially, we thought it was sporadic, non-chromosomal. Then we found a small proportion, the duplication of 11p in about 1% cases. What we found, the 11p was paternal, and that was the beginning of what we call the epigenetic or the genetic imprinting. And because most of these children also developed a kidney tumor called Wilms tumor, and there was a very clear pattern of overgrowth and the risk of tumor development based on the imprinting of different genes. One set of genes being maternal, one set of genes paternal. Depending upon the imprinting phenomena, there was an element of physical abnormalities, so paternal being linked to Wilms tumor. Then we found a very striking deletion, 15q1113 deletion. Although initially we thought it was only related to Prader-Willi syndrome, very interesting condition. But we also found the same deletion in other condition called Angelman syndrome. Both were recognizable, described separately by different people, different experts. What we found that the Prader-Willi case, the deleted segment belonged to the father's homologue, and in the case of Angelman, belonged to the maternal homologue. So that strengthened the concept of epigenetics or imprinting, as you can see from this slide. So that was the beginning of the cytogenetic help in the beginning of the epigenetics, or what you call now epigenomics. So the major contribution of cytogenetics, especially the changing lab technologies from G banding to plomatophase banding, and then moving on to fish analysis. Then we came across a very classic condition. Professor D. George in Philadelphia described children with immune deficiency and also had heart abnormalities. For many years, there was no explanation, and in adults, same condition was called velocardiofacial syndrome. What we found in children, that there was a deletion in the long arm of chromosome 22. This multi-system disease, in which about 60%, 70% children have aortic heart, a congenital heart disease, mainly for pathology. And like in this case, this slide, you can see from this fish, the normal 22 and chromosome, deleted chromosome 22. So this condition opened the way not only for congenital heart abnormalities, but also for other conditions. Then we moved on to chromosome 17 deletion, and we found that these children had a classic presentation and learning difficulties and a lot of self-harm because they could not perceive the pain, no sensation at all. Why? Because 17p11 had genes located for sensory nerve sensation. And similarly, we found it's the same area, two distinct conditions. One is called Charcot-Marie-Tooth disease. Another one is called the hereditary nerve pressure palsy. One is because of duplication of 17p area, which is Charcot-Marie-Tooth disease. One is called deletion, because that is HNPP. As you can see from this slide, when there is a duplication, there is a CMT1A, which is a very important condition. Again, example of non-allelic homologous recombination. So, coming back to the same condition, deletion 22, what I was trying to show here, that there are many genes within that segment. And then this is my patient. We set up the clinic for keeping that child in mind. Now that clinic is very important for managing 22q deletion syndrome. The similar syndromes also are related. The main abnormality, main gene within that 22q deletion area, being the TBX1 gene which belongs to TBX family. The TBX family was also found independently in relation to Holt-Oram syndrome, in which there is a classic HS septal defect, heart abnormality, and very striking hand abnormality, as you can see from this slide. And then the animal studies showed the T-box gene is very important for heart development. So starting from the cytogenetic finding of 22q deletion, we were able to move on and map many genes for heart development. And pediatric cardiologists were delighted, and they use it, as you know, practically every day in their practice. Whenever there is a pharostatology, it's a septal defect, or the aortic wall abnormality, congenital. So they investigate for these children. So even the male infertility, which is very important for couple who are struggling to conceive, about 20% patients have male infertility, a couple I mean, and what we found by pure chance that there was a small area on Y chromosome deleted, long arm of Y chromosome YQ deleted, that was later called AZF. AZ is for azoospermia, and that's set up the main criteria for investigating infertility. So, following this major contribution made by FISH technique, we moved on to a genome-based technique called array comparator genomic hybridization, which is also called the macroarray chromosome analysis, or MCA. In this, the single strand DNA now coming back from double helix to now single helix in the lab in vitro, and then matching that with the reference DNA, one could really easily see on the computer screen loss or gain of the DNA, a specific DNA segment. And that was a major cytogenetic technology, what we call the molecular technology, or what some people call genome-based molecular cytogenetics. And many of my patients, many patients have been clarified. For example, in this case, we were struggling to find the explanation for developmental delay. We found 9p22.2 microdeletion, and that is a distinct syndrome with very important other physical abnormalities. In another case, there was a child with 6-9 balance translocation, but a child also had a developmental delay, which we could not explain, autistic spectrum disorder, we could not explain. But what we found by microarray, by RACGS, there was a microdeletion of 4q, and that explained clearly. So 6 new was incidental finding, which has no consequence to this condition, this child. On the other hand, child had microdeletion 4q. It was de novo because parental chromosomes were normal. We have developed technique how to quantify and validate these RACGS findings. What is also the copy number imbalances. These are used routinely in certain situations, especially when you're looking for dosage kind of evidence for a specific phenotype in a rare condition. So, for example, in this child, it took 2 years for us to investigate, to confirm that this child had two areas on chromosome 15q, quite far away from the Prader-Willi Engelmann area, and these breakpoints were important, and that disrupted the arrangement of the whole chromosome segment. As a result, child had a severe growth delay and severe growth retardation, development delay, as you can see from this slide, including short toes and short fingers. But it took 2 years for us, and then we were able to demonstrate the same finding on using the FISH. So the point I'm trying to make here, that although we have got this comparative genomic hybridization technique, we still use occasionally FISH to validate and also to have evidence picture evidence of that finding. So from the start, we were aware about the chromosome damages occurring in certain conditions, and the Fanconi syndrome or the Fanconi anemia, in which there is a plastic aplasia of the bone marrow along with finger and toe, finger and the forearm abnormalities. In this case, the chromosome breaks are very important. Eventually, we found DNA repair mechanisms at fault, and there are different combination of genes now discovered, all part of the DNA damage and DNA repair mechanisms. So the other striking development in cytogenetics happened what was called the non-invasive prenatal testing revolution. We were able to use all technology, cytogenetic technology, in prenatal diagnosis using amniocentesis, amniotic cells from 15 weeks onward. Subsequently, we were able to carry out the chorion villus sampling or biopsy from 11 weeks onwards. And these stayed for many, many years. But these were all invasive technology because you had to go in either through the abdomen or through the vagina to collect samples. And both are problematic with the risk of inducing a premature abortion, premature miscarriage. Eventually, Dennis Lowe, while working in Oxford, I was also working at that time, and then he managed to develop a technique using the cell-free circulating fetal DNA. And that was a remarkable development, as you can see from this slide here, the fetal DNA maternal circulation. And then this has been used it's used now regularly. As you see, you can do a variety of testing from as early as 7 weeks or 8 weeks of stage. So this massive development, non-invasive prenatal diagnostic, was a major contribution, and although it limited initially only for aneuploidies, and now we have got technology developed for monogenic conditions as well. The same technology was picked up by oncologists who were always struggling to make early diagnosis of solid tumor. So they use the tumor DNA circulating in the plasma, and that's where the whole picture changed completely in clinical oncology. What is now called liquid biopsy in clinical oncology, as you can see from this slide. And so it's a very sensitive technique, and there are many aspects. Most of the solid tumors now, which are sporadic mostly, they can be picked up, and you can see a number of genes can be diagnosed using the liquid biopsy. So liquid biopsy in clinical oncology is a phenomenal development, and moving on from that in tumor oncology or tumor genetics, you can do many things. Specifically, you can plan very targeted molecular therapy for certain rare tumors like non-small cell lung cancer, glioblastoma, or even malignant melanoma, or many other tumors for which there is no clear diagnosis. So the technology changed at this point when we were able to complete the human genome sequence, and the new technology rapidly developed, and we were able to study at the single gene or the multiple gene level. So the single gene sequencing, there are many examples. One of the examples I always use is retinoblastoma, another childhood tumor, very difficult to manage, and which is related to a small region on chromosome 13. Again, incidentally, it was a deletion on chromosome 13 by using the FISH technique, where then the RB1 gene was picked up, and that led to the retinoblastoma genetics sorted out in some detail. So at present now we have got a multi-gene panel for oncology use. As you can see from this slide, practically every cancer has got multiple genes. You can see the example. You can have the limited gene testing only for one or two genes, BRCA1, BRCA2, and then for breast cancer, you can add many more genes. So at present, multi-gene panel for breast cancer, about 43 genes are included. So the power of the same technology, the power of diagnosis is increased tremendously, especially when there is a BRCA1, BRCA2 mutation, negative breast cancer, which happens in certain cancers, especially the ductal breast cancer or the certain other rare type of breast cancer are now BRCA related. So the gold standard for mutation analysis and the validation remains Sanger sequencing, named after Sanger, who was a pioneer, but it was a very laborious technique and only kept for validation. Initially, before the genome sequencing technology became available, it was very time-consuming and and was only kept for special occasions and mainly in the research settings. So the next generation sequencing has changed the whole scenario, and that's why from the point of array CGH or microarray and now next generation sequencing, so the role of cytogenetics and diagnostic medicine has dropped down, remains in a very specific sort of way as a secondary or tertiary backup in the diagnosis. So what used to be the first line of investigation, cytogenetics, now has become the last only when there is required. So coming back to the genome sequencing, what we call the next generation, I think the next generation word is now old. It is simply genome sequencing technology. The most commonly used at present is clinical exome sequencing, as you can see from this slide, that we only target exomes, which are the targeted, the coding area of the genome. Introns are not included, as you can see from this slide. So this is the limitation. We can pick up anything within the exome, or maybe in the boundary, but not within the intron. Intron is a very important area for transcription. So, the clinical exome sequencing refers to if you're very certain of a clinical picture. For example, a patient has got muscle disease, a patient has got a skeletal dysplasia, a patient has got cancer. You know that there are 20 conditions, and together 20 conditions they have got 1,000 exons. So you just plan and focus on 1,000 exons. There's no need to go for the whole exome. However, if it's a multi-system disease or like a child with a rare condition, then you can go for the whole exome sequencing, and that means you go for 20,000 genes in total, which is about 2.1% of the genome. Now, the whole genome sequencing is really in everybody's mind, which is available. Cost is coming down. Used to be several thousand dollars of British pounds. It's come down to less than 1,000 now. In India also, I think one could get whole genome sequencing for about 67,000 rupees. Although it can pick up everything what is there in the genome, but the problem is that you require a very detailed population-based genome sequencing data on the computer to make the proper analysis. If you don't have, then it is a waste of time, a waste of money. Most of the data available on the population reference data is derived from European or the Caucasian people. There's hardly anything from African, from Asian, from South Asian or Indian, which can be used in a proper way. And there are some very sporadic kind of genome sequencing data stored in different labs, but that's not enough. So whole genome sequencing, while it is tempting, while it is very useful, has got limitation because of the background or population-specific lack of population-specific genome data. The other difficulty in the genome sequencing is finding variants or polymorphisms which are of no use. So we have to be very careful what you're looking for. We are looking for very specific disease-causing or pathogenic changes. Intermediate or benign are of no good. And we have got now a very gold standard from the American College medical genetics and genomics, which is used now widely, universally, and that is a big challenge. And there are many different kinds of algorithms available. You can see from in the literature, and this is the one came out recently, and it's quite useful. But again, it requires careful planning, careful clinical phenotype analysis before you proceed for genome sequencing. The other use of the whole exome sequencing, which is used now in India also, what is called preconception carrier screening, especially if you know that there are genetic conditions in those families or the community. For example, the first cousin marriages or consanguine marriages, and the chances of both husband and wife being a carrier are greater than because of relationship, sharing a common ancestral parent in the background, chances of having a child affected with autosomal recessive disease would be much greater. So if we could carry out the whole exome sequencing in the couple prior to conceiving, what we call the pre-conception genetic counseling or carrier screening, you can really advise the couple, and then prepare them for genetic risk, and also prepare them for intervention during pregnancy. And now there's also a case of made of newborn screening using the genome sequencing. As you can see, but there is a lot of information which we need to clarify, as I mentioned previously. So the important element in future, which is happening but still remains in the research arena, is the functional genomics. So our job in the clinical medicine is the clinical picture called phenotype. And if we have got a variant of uncertain significance, then we can use a variety of technology, transcriptomics, metabolomics, and epigenomics, all these things put together. And that's the way we'll proceed. So unless we have got this kind of technology available, there's no point to carry out the genome sequencing, because you'll have the data, huge data sitting in the computer. You will be struggling, scratching your head what to do with that data. And money has been spent, and you have taken blood or saliva from the patient, and parents are looking at your face, and you are struggling not to provide an answer because you have not carried out full, complete workup. So with the functional genomics in the future, that situation will change. So at present, the genomic healthcare or genomic medicine is widespread in practice. It started from preconception, prenatal testing, newborn screening, disease susceptibility, screening, diagnosis, prognosis, including treatment, and then monitoring in the healthy people, healthy families. And as you can see, the designing therapy is now in everybody's mind. And this is a classic slide. You can see from this that the cancer therapy is personalized, and that is happening in certain cancers, in certain conditions, not only oncology, other areas as well. And that is the future of genomics. Again, fundamental thing would be the genome technology. Without genome technology, you will not be moved any forward, whether it is cytogenetics or whether it is genome sequencing. The other area of genomics, which is extremely important in drug prescribing, is the pharmacogenomics. As you can see from this slide, so if you got a variants, which say theoretically 4 variants, a higher dose, lower dose, or a new drug or optimal dose, all these things can be worked out based on the genome variants. Recently, only last week, this paper came in Lancet, and a huge study, about 41,000 patients in the UK and Europe. And they have documented with solid evidence of 12 gene pharmacogenetic panel, and that these genes are important for adverse drug reactions. And they found about 40% cases related to these things. So testing for drugs prescribing is going to be, it's already happening, but it's going to be really a requirement by the regulatory body like the FDA or anything, any other country. So the future developments are very important. We all talk about the artificial intelligence. So these days, without even thinking about the sequencing, you can really predict what sequencing abnormalities one could have. For example, in this case, you have got a child who is dysmorphic. Child's image is analyzed and classified, put in the computer, and then the computer has got reference data from different syndrome, different phenotypes, and you can develop the picture, and you can also forecast what kind of genome sequencing or genome abnormality might be there in the child without even taking child's blood, without even touching the child. You just have got child's picture, and the clinician has taken permission from parents, and the computer scientist sitting there who's expert in artificial intelligence can do. The advantage of this thing is that then a lot of money saving will be made for the family. In a poor country like India or other poor countries, this would be a tremendous advancement. So there are many computer experts could be trained in artificial intelligence. And then you know that this child is likely to have that syndrome, and this is a likely mutation or variant present. Go for it, and you can save huge cost and time and be very specific. That is going to be the future kind of what you call targeted sequencing. We have made huge progress in treatment, as you can see from this slide. The new drug for muscular dystrophies have come. The very expensive drug for spinal muscular atrophy is on the market. So these are real examples. These are new drugs. They are based on gene and genomic understanding of different conditions. So it's no longer a hypothesis. It's no longer fiction. It's all there. It's up to us to really make a good case. And what is good case? Very specific genetic genomic testing. So there is no shortcut. Doctor looking at the child, examining and collecting all clinical picture in detail, and then making the case for a very expensive medication. Because for spinal muscular atrophy, this drug is called what you call Zolgensma, costs about 1.5 crore rupees. Similarly, for metabolic conditions, we have got all kinds of enzyme replacement which are available. Again, these are very expensive medicines, and they require careful workup. Absolute 100%, 200% specific diagnosis. That means you have to use the genetic or genomic technology to the last point, including functional genomics. In the blood diseases, recently you might have heard the CRISPR-Cas9 technology has been used successfully to treat sickle cell anemia, sickle cell disease, which is a very classic hemoglobinopathy or beta chain. And this lady has been treated in Mississippi, and that is, that CRISPR-Cas9 technology discoverer were given the Nobel Prize for right reason. And the other drugs for thalassemia, hemophilia A, and hemophilia B all available. And similarly, there are many nutritional supplements for different metabolic conditions also available. But the point I'm trying to make, you need to have a very specific diagnosis. You cannot do just a guesswork. Okay, let me prescribe that, let me try that. That's not going to happen and should not be accepted. So in conclusions, the science of cytogenetics is the cornerstone of modern genetics and genomics. The contribution of cytogenetics should not be ignored. The conventional methods have gone down on the list, but they remain pivotal in certain areas. For example, mosaicism, balanced translocation, in some cases, the confirmation of the gender, and of course, the FISH technology, the molecular cytogenetic technology by FISH is very important for validation and documentation. and variety of genome lab techniques are available. Sequencing is becoming now a norm, and we need to refine it by functional genomic studies, and that should be part of any genomic lab in the future. If the genomic lab hasn't got this functional genomic facility, so that means the lab is not fully functional. In future, we need to be using genomic information by precision testing for drug selection, new drug applications, and targeted therapy. So I hope I have taken all of you through this long journey of genetic and genomic technology using different examples. And so those who are newcomers in the field, they have a bright future, or those who have spent time looking at chromosomes down the microscope, they will be relieved that they can now relax and let other people do the work. Thank you very much.
Good afternoon, everyone. Thank you, organizers, and especially Dr. Neetu, for giving me this opportunity to be here today in this lovely conference of cytogenetics and molecular. I will not take much of your time because session has already progressed. I will like to invite Dr. Arundhati Sharma as the next speaker. She has done her graduation from Osmania and post-graduation from Pune University in genetics and molecular biology. She did her PhD in human genetics from Nizam's Institute of Medical Sciences and Osmania University, and her subsequent postdoctoral work was in the Department of Medical Genetics, SGPGMS, Lucknow. Later, she has joined as Associate Professor of Genetics in the Department of Anatomy, AIMS, New Delhi. Her works include teaching, training, and providing diagnostic facilities in the field of human genetics. Her laboratory is providing diagnostic and patient care services, conventional cytogenetics, as well as other chromosomal studies, molecular cytogenetic services using fish and various genetic, numerical, and structural abnormalities detection, cancers and other genetic conditions, prenatal diagnostic and genetic counseling services, chorionic villus sampling, amniotic fluid sampling, cord blood, skin biopsy, tumor tissue analysis, etc. for detection of chromosomal aneuploidies and single gene disorders. Her research interests include genetics of endocrine and eye disorders and identification of biomarkers for prognostic and diagnostic purposes for various cancers. That especially interests me. Ma'am, may I request you to please. Thank you.
Good afternoon, respected chairpersons and my dear colleagues and my younger friends. It is always a pleasure to come back to Lucknow, and I must thank the organizers for giving me this opportunity to come back here. I have been working in the field of cytogenetics. Okay, let me just tell you, like, my lab is in the Department of Anatomy. Anatomy, basically, we teach the students a little bit of genetics in the first year, the undergraduates. So we also provide laboratory diagnostic services. So it is cytogenetics, and mostly the cases are referred to us from the departments of endocrinology, gynecology, ophthalmology, etc. So the diagnostic services are being provided for cytogenetics and a little bit of prenatal diagnosis. Molecular analysis I do, that is my research interest. So it includes disorders of the eye, the endocrine disorders, etc. So what I am going to present today, because there's been I think an overload of cytogenetic studies, so I would like to just present what work has been done in my laboratory in the past about 12 years. So it's in fact more than 12 years. So the majority of the cases which are referred to our laboratory are for cytogenetic analysis include those of recurrent spontaneous abortions, primary amenorrhea, secondary amenorrhea, and infertility, both male and female. So roughly, as the literature also cites, about 4 to 6% of all these conditions have a cytogenetic abnormality. So this is just to give you the percentage. So most of the, about 50% of the cases are RSA, that is recurrent spontaneous abortions. Now here I must tell you that there is always a tussle which goes on between the gynecologists and the geneticists, because gynecologists feel that 2 and more spontaneous abortions warrant a genetic testing, a karyotyping, and geneticists feel that there should be at least 3 spontaneous abortions which warrant a testing. So because of that, but still we take all the cases, and about 50% are of RSA, and followed by primary amenorrhea. Awaaz kam? Okay. So I'll just tell you the results that we got for recurrent spontaneous abortion. So these are some of the cytogenetic abnormalities we found. One was the isochromosome of the Q arm of X chromosome. Then, then the what do you call translocation between chromosomes 3 and 15, and here the bottom panel left shows the translocation between chromosomes 5 and 19, and translocation 11 and 22. Then the first panel on the left shows, top left shows deletion of the short arm of X chromosome, inversion 3, and inversion 9, this is a very polymorphic variant normally found. Robertsonian translocation, that is involving chromosomes 14 and 21. And deletion of chromosome, the P arm of deletion of the Q arm of chromosome 1, another Robertsonian translocation between 13 and 14, and XQ deletion. So these are some of the changes that we find in RSA patients. So now imagine a situation where we have about so many patients coming, and only about maximum about 5% of the cases we give a report which is abnormal. Otherwise, most of the cases are normal report, but their problem still persists. So we thought, what should we do about it? I mean, try to look at the molecular status. So there have been many factors which are associated with RSA, especially factors which regulate the normal pregnancy are those which are the immune factors, like the FAS ligand, the various interleukins, TNF alpha, etc. And among these, HLA gene also plays a very important role. So HLA gene polymorphisms have been studied, and especially the 5' and the 3' regulatory regions harbor certain polymorphisms which have been found to be associated with RSA. So we also studied these. In fact, we wanted to study the 5' upstream changes, and especially there is a CpG dinucleotide which harbors, if there is a CpG the island over there, then there happens to be a methylation. So now this methylation or this epigenetic change also has a link with RSA. So we studied this in a group of about 200 RSA cases, and we found that there were two variants in the 5' upstream region which were protective of the RSA. Like they were homozygous at the CC locus of the polymorphism, which was protecting the patients from recurrent spontaneous abortion. So the ones who did not have CC genotypes were more prone to get RSA. Similarly, there was another interstitial deletion, 14 base pair deletion in the 3' region, downstream region, which also had a effect on the RSA. So this is some work which we have done at the molecular level. Then the other abnormalities that we have found, now I come to the second category, that is the Turner syndrome, which accounted for about 1.4, 1.6% of all the cases which were referred. So the most common is for 45X, that is Turner syndrome. Then you have other variations of Turner syndrome which can be mosaics or which can have isochromosomes, or there can be a deletion of the P arm or the Q arm of the X chromosome that also leads to Turner syndrome. So again, then we thought that when we are having these cases, why not also look for the presence of Y chromosome in these individuals. So it was a short study of about 42 cases in which we found that about 27 cases had 46XX karyotype, and 4 cases were 45X. Presence of Y was seen in about 11 cases, and XQ deletion in 3 cases. So now presence of Y is one has to be very careful and one has to report it, because presence of Y actually enhances the risk of gonadoblastoma in Turner syndrome patients. So and about 6 to 9 cases of Turner syndrome show the presence of Y chromosome. So it is just the identification of either the Y chromosome or Y derived material which is important, so that a simple prophylactic gonadectomy can be done in the patients. So now when we see such Turner syndrome cases, there are 3 ways in which we try to evaluate. One is the routine standard karyotyping, where we try to look for the presence of Y, or we can do the SRY gene amplification by molecular methods, that is PCR, or do FISH for the presence of Y chromosome. Then the third category, that is infertility. So male infertility, the most common cause which we have seen is Klinefelter syndrome, and which is 47XXY karyotype. Sometimes we also find mosaics of mosaic Klinefelter syndrome also, and different numbers of the X chromosome. One interesting case that we came across was an infertile male with karyotype 46XX. So this led us to think that there surely must be some Y material which is causing that maleness to the individual. So we tried to amplify the SRY gene, and we found that it was indeed present in this individual. Another case of infertility was a man, a patient with hypospadias, and he had undergone multiple repair surgeries, but they were but to no use. So then he was sent to us for karyotyping, and we found a small deletion in the chromosome 1 in the short arm just below the centromere. So because this was in the initial phases, we wanted to make sure that whatever we see is a deletion. And then we tried to validate this by using FISH, and it indeed showed us that there was a deletion of the 1P36 region, 1QH region in this particular individual. The other categories identified were trisomy 21, Down syndrome. This is typical. And one major category which comes, and when we do the normal karyotyping, we normally see 46XY. So these are cases of DSD, And there are several, as this slide can show you, there are several genes which are implicated in the causation of disorders of sexual development. So we tried to test or analyze about 4 genes, that is the SRY, the DHH, DAX1 and the NR5A1 gene. So now I'll just give you an example of about 3 to 4 families. Now this is a patient with a brother and a sister, and this patient came to us for karyotyping. So she had a small infantile uterus and irregular hormone levels, and karyotyping showed that it was 46XY chromosomal complement. So when we did the molecular analysis for this, we found that this particular individual harbored a novel mutation in the SRY gene, which was actually generating a stop codon. Similarly, there was another family with about 5 people. 3 of the sisters, which I'm showing you here on the slide, were all similarly affected. All of them presented with normal breast development, and other secondary sexual characters development, and ultrasound showed a small infantile uterus, irregular hormone levels, and cytogenetic analysis showed a 46XY chromosome complement. So when we tested these individuals also, we found a mutation in the SRY gene in these all the 3 sisters. In fact, we wanted to test this brother also, but the brother was not willing to get tested. Then another family with the same DSD we found a mutation in the DHH gene in this particular individual, a heterozygous mutation in the patient. And another family where one patient was affected, we did not find any mutations in the coding region, but we found mutations in the intronic regions in the NR5A1 or the SF1 gene. Now for a short thing, I'll just present some results from the prenatal diagnosis that we had provided. So normally at our center, the amniotic fluid amniocentesis is mostly preferred if we want to look for karyotyping. Of course, CVS is also done, but amniotic fluids cultures were done mostly, and with a fairly good success rate. And these are some of the abnormalities that we found, that is polyploidy, trisomy 21, Robertsonian translocations, trisomy 13, turnomosaics. I'll just share with you some interesting cases. Now, this was a case in which triple screening was negative. There were no gross ultrasound malformation, but the major indicating factor was oligohydramnios and severe hydrops in the baby. So when amniotic fluid culture was done in this particular case, I found a mosaic of diploid and tetraploid cells, about 45% of them. So then by that time the patient delivered, and the baby girl was born who died after 2 hours. And then what we did was we collected the cord blood of from the patient, and we did the same test in the cord blood, in which again we found that there was a presence of diploid and tetraploidy in the cells. So then we thought it is better to evaluate the parents. So the samples of the parents were taken. The father's karyotype was normal. They had a normal daughter earlier. So her karyotype also was normal. But surprisingly, we found that the mother had a low-level mosaicism. In fact, I can't call it low level also. 20% of her cells were again of diploid tetraploid mosaicism. We got the mother evaluated to see if she had any other problems, but except for slight dysmorphic facial features, she was otherwise normal. Now, this was one of our first cases. So this particular family had a previous child born with Down syndrome, one normal child, and 2 abortions. Now later they came again. She was pregnant, and they came again, And when we did the prenatal for her, we found that it was a trisomy 21 fetus. So that was aborted, and then they went in for medical termination, and then we collected the cord blood also, and we tested the cord blood, and the same results were seen in this. This was just to validate. Now this was an interesting case, a lady all the way from Bihar with a history of 8 recurrent spontaneous abortions. The presence of hydrops was there, and she was referred for prenatal diagnosis. So initially, when we did the amniotic fluid cultures, we found a Robertsonian translocation, that is between 13 and 14 chromosomes in the fetus. So, I mean, just out of interest, I thought it is always better to test the mother also. So we did the mother's karyotyping also, and we were surprised to find that she was also a carrier of the same Robertsonian translocation. And it was a surprise that in spite of all the 8 abortions that she had undergone, she was not any time referred for a routine cytogenetic or a karyotyping test. Now this lady was counseled about the findings of the report, and she was willing to undergo with the the pregnancy, and she delivered a healthy carrier boy, a healthy boy who was a carrier of the Robertsonian translocation. And after a few years, about 4-5 years, I again met the lady in the hospital, and her son was doing well, and she had come again with the next pregnancy also. So she had a second child also, and then of course she was not referred, so I do not know whether the second child was a carrier of the translocation or it was a normal baby. And this was a case again of the lady was referred with advanced maternal age, and again a history of recurrent spontaneous abortions. The mother herself had some cardiac issues. She had short stature and what we called as migrognathia or fish-like mouth. This was the only thing, and I persistently had a feeling that I must check this lady also, I must do her karyotyping also, but that time it was not warranted. So first we did the fetus's karyotype, and we found that it was a mosaic, a Turner mosaic of, that is 46XX, XX with deletion of the Q arm and 45X. So once the report was given to the patient, and when we talked to her, we asked her that we would like to do her karyotyping also. So we took her blood sample and her husband's sample. Husband was normal, but we found the same kind of chromosomal karyotype in the mother also. That is, the 46XX was the normal, and 46 the deletion of the long arm of X chromosome. That was a low-level mosaicism which was found in her. And this actually sort of gave this thing to me, because right from day one I had a feeling that this lady must be a mosaic for Turner syndrome. So this is just to tell you the importance of testing, of course, the patient, but testing the parents is also very, very important. And so there were similar other cases where we have found trisomy 21 and Turner mosaic in another case. So this case number 8 was trisomy 13 we found in this particular patient. And this was interesting, case number 8, where the fetal ultrasound at 21 showed multiple structural anomalies. And when we did the analysis, we found that the fetus was actually having a double aneuploidy, that is trisomy 21 as well as a Turner mosaic. So I haven't done much of cancer cytogenetics, but then as part of a small MCH research thesis we had done, where we wanted to see whether we could culture the FNAC samples. So this is fine needle aspiration cytology. So these samples that we get, so these whether we can use those, because they are single cells in suspension, whether they can be used to culture. So we found a success rate of about 55 to 60% in this, and we found these various abnormalities in the chromosomes in these patients of neuroblastoma. Now, in neuroblastoma, they have a very this thing of using these markers for diagnostic and prognostic testing as well as for staging. So this the NMIC amplification is one of the markers which they use for staging also. So then we did FISH to see if we can detect the NMIC amplification in these cases. This is just to show you the amplification of the NMIC in the FNA derived cells. Then coming to another variant, that is Prader-Willi syndrome. We have heard much about it, Prader-Willi syndrome. So normally when such a patient is referred for genetic testing, it is always better that you do the complete testing, which includes karyotype validated by FISH, and also do the methylation specific PCR, because this also results as a due to imprinting or methylation of the genes in the chromosomal long arm, 15 chromosome long arm, bands 1,1 to 1,3. So this is the result of that. First we did the karyotype, it did not show us any deletion. So that was validated by the FISH, and FISH also did not show us any deletion. Then we did the methylation specific PCR. So if you can just see here, this is the methylation band for the patient. These are the control samples. So if there is methylation of the genes, then you will not see a band in the unmethylated region. So this confirmed that there was methylation of the promoter region of the SNRPN gene, which is responsible for one of the causes for Prader-Willi syndrome. So all these that I am showing you are published as separate papers. I haven't quoted them here. Another category which comes very frequently, very normally for cytogenetic analysis is cases with ambiguous genitalia. So this is a major attribute to this is due to congenital adrenal hyperplasia, in which there is a gene CYP121 A2 or 21 hydroxylase gene which is mutated. So when we did this for the patients, normally they turn out to be having a normal karyotype. So we have done extensive studies at the molecular level in such cases of CAH also. Another category or another case is aromatase deficiency. Now these cases, in fact this was our practical experience, most often they are misdiagnosed as CAH at birth because of the ambiguous genitalia, and in this case this particular patient was diagnosed as CAH, and this diagnosis was retained till she was about 13-14 years old. Then she came back with additional features of estrogen deficiency, androgen excess, etc., and which was not common or which is not seen normally in CAH. Then there was again, we had to sit with the mother, the parents, and again ask them, and then we came to know that the mother also, there was maternal virilization also when the mother was pregnant with this particular child. So this suggested that this could be a case of aromatase deficiency, and therefore we tested CYP19A1 gene, and we found a mutation in this particular patient. This is a recessive case. The patient was homozygous for the mutation, and the mother was a carrier of the mutation. So this actually tells us that especially in cases of CAH, it is always better to even suspect aromatase deficiency and accordingly try to move with the diagnosis and get the required testing done. So I think I'll end with this. There are a few more cases, but after a lunch session it is difficult to listen, I guess, and to talk also. So with that, I thank you for your patient hearing. Thank you.
Thank you, ma'am. Any questions regarding this session? So, after this nice talk, we proceed to the next speaker. I would like to invite Dr. Deepti Saxena. She has done her MS in Obs Gynae from SN Medical College, Agra, and has done her DM in Medical Genetics from SGPGI, Lucknow. She is currently an associate professor in Department of Medical Genetics at SGPGI, Lucknow. Her areas of interest are dysmorphology, skeletal dysplasias, prenatal diagnosis of fetal malformations, and reproductive genetics. She has various research publications in various national and international journals, and her research interests are in the ongoing projects of craniovertebral junction anomalies, fetal malformations, and dysmorphology. Dr. Deepti, please.
Good afternoon, everyone. First of all, I would like to thank the organizers for inviting me for this event. I would be talking about utility of microarray in prenatal diagnosis. As you all know that prenatal diagnosis is an important part of genetic services around the world. So we know that congenital malformations are seen in around 3% of all pregnancies, and most commonly they involve cardiac malformations, central nervous system malformations, skeletal and urogenital malformations. In 50% of them they may be inherited, and the cause can be identified by chromosomal microarray as well as next generation sequencing. So the optimal care is best achieved by a multidisciplinary team which includes obstetrician, fetal medicine specialist, geneticist, perinatal pathologist and genetic counselors. So as we all know that chromosome may constitute around 100 million bases, and on this chromosome we have various copy number variations ranging in size from 30,000 to 3 million bases. Then we have a gene ranging around 3,000 to 5,000 bases, and on that gene we can have a sequence change involving one base also. So this is a routine karyotype picture. So metaphase cell contain around 400 to 500 bands per haploid genome, and on karyotyping we can detect deletion or duplication ranging in size from 5 to 10 megabase. But when we have to look for smaller variations, then we have to search for another methods. So karyotype can detect major chromosomal abnormalities as we have seen in last lecture. It can detect aneuploidies, translocations and deletions or duplications more than 5 megabase. So fetal karyotyping is done by chorionic villus sampling, which is done at around 10 to 12 weeks of gestation, and we can do amniocentesis after 16 weeks of pregnancy. So reporting time of karyotype is around 14 days. Most commonly we can detect trisomy 21, trisomy 13, trisomy 18 and monosomy X, that is Turner syndrome. Also polyploidies can be detected on karyotyping. So abnormal karyotype is seen in around 16 to 30% of cases with structural malformations. The risk of chromosomal abnormalities increase with multi-system involvement. Suppose if only a single system is involved, then the chances of chromosomal abnormality is around 17%, which increases to 30% in case of multi-organ involvement. So copy number variations are segments of DNA of 1 kb or larger which are present at a variable copy number in comparison with the reference genome. Approximately 12% of the human genome consists of copy number variations, out of which majority are benign, which are inherited, and majority are less than 500 kilobase. These copy number variations do not contain important protein coding genes. So what is this? It is an array of flowers, it is an array of cars, and it is an array of individuals. So DNA microarray is also an array of orderly arranged microscopic DNA spots which are attached to a solid surface. Each DNA spot contains small amount of specific DNA sequence which is known as probe or reporter or oligos. So these probes can be a short section of a gene or other DNA element. So this is a representative picture of a microarray chip. So here you can see these are small DNA fragments which are attached to this chip. These fragments are known as probes. This is the actual microarray chip that we are using, and on this small region the sample of the patient is loaded. So the principle behind microarray is that on the chip there is a DNA probe which gets hybridized to the target DNA, leading to binding of this test probe with the patient DNA. So there are various types of microarrays. This comparative genomic hybridization. In this, the comparison of the patient result is done to a controlled result. In SNP array, we compare the patient result with a set of established controls, that is reference values. In SNP array, there are two types of probes for SNPs as well as for copy number variations. So they are also known as hybrid arrays. So this is a representative picture of array CGH. So both patient DNA as well as reference DNA is mixed in equal amounts, and then it is hybridized to the microarray chip. So at points where there is no difference between the patient and reference DNA, the color will change to yellow. At places where the patient has a duplication, red color will predominate, and at places where the patient DNA is having a deletion, green color will predominate. So this color coding gets converted into a readable form, and then we can detect whether deletion or duplication is present in patient's DNA or not. This is the SNP array. So the size of chip is almost equal to a matchstick. In this, there is hybridization of just the test DNA, and deletions and duplications are identified by the different intensity of hybridization, which is compared with probes from a normal diploid sequence. So the patient DNA is only used in this method. There is no control DNA. So this is a microarray chip. So we have different oligonucleotide probes. On these probes, the patient DNA is hybridized. So the amount of sample will determine the intensity of the probes. The remaining probes are washed off, and only the strongly paired strands will remain hybridized. So these target sequences are fluorescently labeled, so they will generate a signal. So the total strength of the signal from a spot will depend on the amount of target sample. Suppose there is a deletion, the signal will be weak. Suppose if there is a duplication, then the signal will be strong. So by comparing the intensity of this signal to a reference data, we can say whether a deletion or duplication is present or not. These are the various material which we use for chromosomal microarray. So we have chip, various reagents, the wash buffers are used. The process is completed in 4 days. So major steps are: we take the genomic DNA. That DNA is digested into small fragments. Then the small fragments are ligated to the chip. Then we do PCR to increase the number of DNA molecules. Then the molecules are purified after PCR. Then again fragmentation into further smaller molecules is done. Then labeling consists of combining the DNA molecules with the fluorescent dyes. Then the sample is hybridized to the DNA chip. After that, the excess probes are washed off. Then staining is done, and in further by scanning we read the relative quantity of the signals produced from each probe. So as we all know that there are different types of microarrays. Some are targeted microarrays which are developed for specific regions of the genome. Some are whole genome microarrays, so they cover the entire genome and they consist of overlapping clones or high density oligonucleotides. So the array which is of a very high density probes is Affymetrix cytoscan array. So it contains around 2.6 million probes, out of which 7,50,000 are SNP probes and around 1.9 million are the oligonucleotide probes. So these probes are distributed all over the genome. In the target areas the density is more, whereas in non-target areas where the gene density is less, the space between the probe is more.
And there are other platforms where the total number of probes is less, such as 44K, 180K, 400K, 850K, and 1M. So the number of probes will determine the resolution of the testing platform. So the resolution is determined by the type of probes that we are using, the spacing of the probes, and the number of probes that are used to identify a copy number variant. We can use various size filter cutoffs during data analysis. So if we are using a chip with a higher probe density and we are using a small size cutoff, then we will detect more number of CNVs, so there will be a greater yield. And in one study it was estimated that when we are using a chip with 2.6 million probes versus a chip with 44,000 probes, there was increase in yield by 23%. But majority of these copy number variations were variant of uncertain significance, so the increase in yield for pathogenic copy number variations was only 6%. So we have to choose wisely which kit we are using depending on the indication. As we know that if we increase the probe density, then the number of variant of uncertain significance will increase. That will pose a problem in post-test counseling. So what are the uses of microarray? We can detect DNA copy number gain or losses in cases of chromosomal rearrangements. If we are using SNP array, it will also detect long regions of homozygosity, uniparental disomy, mosaicism, maternal cell contamination, and polyploidy. So the indications of prenatal microarray, it can be done in cases with structural malformations in fetus, which is detected by ultrasound or MRI. It can be used as an adjunct to karyotyping. Suppose we identify a marker chromosome, then to know what is the constituent of this marker, we can do microarray. If there is a balanced chromosomal rearrangement on karyotyping, then to detect any submicroscopic loss or gain, we should do microarray. If there are multiple soft markers on ultrasound, if the serum screen is positive or NIPS is positive, if there is advanced maternal age, either of the parent is having a balanced chromosomal rearrangement, or there is a history of previous pregnancy with submicroscopic chromosomal abnormality. Some cases can be due to parental anxiety. Now various societies such as American College of Obstetrics and Gynecology and Society for Maternal Fetal Medicine recommend that microarray should be used as a first tier diagnostic test for all fetuses, whether they are having any malformation or not. Whereas Canadian College of Medical Geneticists recommend microarray only when multiple fetal malformations are present or when nuchal translucency is more than 3.5 millimeter. So we should offer microarray whenever we are doing invasive testing for any indication. As it is a comprehensive and sensitive test, it can detect submicroscopic abnormalities. The reporting time is fast. It is around 7 to 10 days because we do not need to culture the cells as we have to do in case of karyotyping. Detection rate by microarray in the presence of fetal abnormalities is around 6 to 8%, whereas in case of structurally normal fetus, it is 1 to 2%. In cases with multiple malformations, detection rate may increase up to 13%, and it also depends on the organ system affected, with high yield in case of cardiovascular malformations, central nervous system malformations, and low yield in cases of urinary tract malformations. The most commonly observed copy number variations are 22q11.2 microdeletion and duplication in cases of cardiac defects, 17q12 microdeletion in genitourinary defects, and 16p11.2 duplication in gastrointestinal defects. So these are few studies from our country. So this was done in my center. So we have done microarray in 128 prenatal cases. The detection rate in cases with structural malformation was 8%, and the overall yield was 5.5%. This was another study from Gangaram Hospital. So they have observed a yield of 9%, and over and above karyotype the increased yield was 3.7%. In their cohort also, the highest yield was seen in cases with abnormal fetal ultrasound. So benefits of microarray: we can reassure the prospective couple, but sometimes we may come across a variant of uncertain significance. So in that case, this may create confusion also. We may provide option of termination in case of a pathogenic copy number variation. It should be done prior to fetal surgery. If you are planning for surgery in cases of congenital diaphragmatic hernia or neural tube defect, then we should first check whether the fetus is chromosomally normal or not. It may prevent operative intervention in postnatal cases if the prognosis is poor, and it may also give time to parents for birth of a child with special needs. We can also counsel regarding impact on family and that what is the risk to siblings. So the limitations of microarray, it cannot detect balanced rearrangement, which can be detected by karyotyping, such as reciprocal translocation, Robertsonian translocation, and inversions. It will not detect the imbalances in the regions which are not represented on the microarray platform that we are using. It will not detect the single nucleotide variations. For that we have to use another method such as Sanger sequencing or next generation sequencing. Then polyploidy changes will not be detected on array CGH. It can be picked up by SNP array. Low level mosaicism less than 30% will not be detected. Imprinting disorders will not be detected. Heterodysomy and will not be detected. Also, there will be difficulty in interpretation of variant of uncertain significance. So there are various uncertainties when we are doing prenatal genomics. Some uncertainty is regarding the diagnostic yield, because these investigations are costly. So whenever patient is paying for a costly investigation, they will think that it will give all the answers, but sometimes in spite of a malformation in the fetus, microarray will come normal. So this has to be explained before offering any test. Then sometimes you may come across a chromosomal abnormality which is not related to the phenotype that is present on ultrasound. Because so this has to be explained. Sometimes there may be a copy number variation which shows incomplete penetrance or variable expressivity. Means it is seen in various individuals, but some of them are having a disease whereas others are completely normal. So in that case, in case of prenatal cases, as we don't have any clinical feature that the fetus is having intellectual disability or some organ some intellectual disability or limitation in function of any organ, then we will not be able to counsel that whether this particular copy number variation will have any effect in the postnatal life or not. Sometimes you may come across some secondary findings that are not related to the primary indication of testing. So in these cases there will be uncertainty and it will be difficult to counsel the family. So coming to mosaicism, mosaicism is the presence of two types of cells in a sample. So it is seen in 1 to 4% of cases when diagnosis is done by chorionicular sampling, and in 0.1 to 0.3% in cases of amniotic fluid. So in case of karyotype, we are manually selecting the cultured cells. So there is a difference in the level of mosaicism due to decrease in number of cells. There will be decrease in the number of trisomic cells, whereas the number of monosomic cells will increase due to the culture. In CMA, we are using uncultured cells, so there will be original proportion of normal and abnormal cells. But in case where there is a mixture of monosomy as well as trisomy, like in this example, in some cells there is an extra X chromosome, whereas in some cells there is a loss of one X chromosome. So in this case, microarray will not be detect the abnormality. So this is a representative picture of the software that we are using for chromosomal microarray analysis. This is chromosomal analysis suite. So we have to first select the size of copy number variation. So we can apply a filter. Here you can see we can select the marker count. So how many probes should be there to a correct identification of a copy number variation. Then we can select the size of the copy number variation. Usually for gain, we take 400 kb as the cutoff, and for loss we take 200 kb as the cutoff. So this blue color bar is showing the presence of gain. So this gain is there at chromosome 10, position P 11.21. The size of the gain is 714 kb and it contains 1 OMM gene. So this complete bar is showing the entire region of this particular copy number variation. This bar is showing a deletion. So usually blue color denotes a copy number gain and red color denotes a copy number loss. So the various softwares are then used to interpret whether the observed gain or loss is pathogenic or benign or variant of uncertain significance. So the softwares that we use is PubMed, then UCSC Genome Browser, then Online Mendelian Inheritance in Man. So it is the online catalog of the various genetic disorders that have been identified. Then Decipher, it is also a disease database of copy number variations that has been identified in previous studies. Same is ClinVar. Database of genomic variants is database of normal population. So the copy number variations which are observed in normal population is deposited in this database. Then we have International Standards for Cytogenetic Array Consortium. It is also a disease database. Then we have database of genotype and phenotype. It is also a disease database. So in these databases, various studies have deposited their findings, so we can know that whether the copy number variation that we are observing in our patient is present in these databases or not. So in the same software, chromosomal analysis suite, there are various links to these repositories. This is the link for ClinGen, link for UCSC browser, link for ClinVar, and then DGV, Ensemble and Decipher. So we can directly go to the respective websites and then we can check whether our region is present in these particular databases or not. This is a quick snapshot of DGV. So this is a database of genomic variants. It is a catalog of genomic structural variations which are present in normal human beings. So if any variation is present in DGV, then it is considered to be a normal variation. Then UCSC browser, it provides complete information regarding a particular copy number variation, what is the total number of genes, whether it has been reported or not. Then Decipher is a disease database, so here we can see whether this particular chromosomal deletion is associated with any phenotype or it is not reported in this database. Same is ClinVar. In this there are various entries denoting the variant as benign, pathogenic or likely pathogenic. So if our entry is present in any of these databases, we can directly interpret the inference. Then this is the ACMG scoring. So American College of Medical Geneticists has provided a scoring system which is available on ClinGen website. So they have given different parameters by which we can calculate whether the particular copy number variation is pathogenic or not. So the scoring depends on number and the presence of protein coding gene, whether the copy number variation overlap with known pathogenic entries or benign copy number variations. We can evaluate literature and public database, and we can also denote the family history or inheritance of the patient. So if the score is more than 0.99, then this copy number variation will be classified as pathogenic. If the score is 0.9 to 0.8, then the variant will be likely pathogenic. If the score is between 0.89 to minus 0.89, this is variation of uncertain significance. So the category for variant of uncertain significance is very broad, and therefore the majority of copy number variations may fall into VUS category. So again, coming to criteria for CNV classification. So pathogenic CNVs are large aberrations. They are very large in size, several megabases in size with clinically relevant genes, or either they should encompass known microdeletion or duplication syndrome. These entries may contain known genes which are responsible for a specific pathology and may contain CNVs that are previously described in specific disorders. In likely pathogenic entries, these copy number variations are described in some case reports. They contain genes, the function is known, and they may be responsible for the clinical features of the patient. The CNVs that do not have a clearly defined clinical significance at the time of reporting are classified as variant of unknown significance. So for prenatal cases, European Cytogenetics Association has recommended that these findings should not be reported, whereas Canadian College of Medical Geneticists says that variant of uncertain significance which are more than 500 kb in case of deletion and more than 1 megabase in case of duplications should be reported. So for each country there should be specific guidelines so that there is uniformity in reporting guidelines. Likely benign copy number variations occur in healthy people and have been described in few cases in general population, whereas benign are polymorphisms that are reported in various databases such as database of genomic variants. These aberrations do not contain may not contain any genes, so therefore they are classified as benign. So to interpret a microarray data, we should have a database to identify common copy number variations specific to the population. They should be interpreted on the genome build as the data generated from the platform. Microarray analysis of parental samples may be required to identify the inherited copy number variations. The copy number variations that are interpreted as benign or likely benign should not be reported in the final report, and the classification should be based on the evidence which is available at a given point of time. The interpretation should consider the size of the copy number variation, what is the location of the breakpoints, whether copy number variation is overlapping with the clinically relevant region, or whether it has been reported in database of healthy control population. The gene content of the affected region should be looked, and the presence of clinically significant genes should be sought. We should see whether the copy number variation is inherited from the parents or it is de novo. Now, while reporting, the report should include the patient demographics, the indication of testing, what is the array platform that we have used, what is the probe coverage on that platform, the resolution of analysis, which was the software program that was used for analysis of microarray data. We should also give the limitations of microarray testing, that is, it cannot detect low-level mosaicism, balanced rearrangement, etc. The report should also include the location of the copy number variation, the chromosome number and cytogenetic band, size of the copy number variation, and the coordinates along with the genome build that has been used. The copy number state, that is gain or loss, should be specified. What are the genes involved in the copy number variation should be given. If we have a large imbalance, we need not report all the genes that are present in that copy number variation, but we can write the name of the syndrome or the most clinically relevant genes. For the variant of uncertain significance, all genes in the interval should be included in the report. Now coming to some case examples. So this case was referred at 23 weeks 1 day with high risk for trisomy 21. On ultrasound, there was single umbilical artery. The shape of the skull of the fetus was strawberry shaped. There was retrognathia, there was fetal ascites and polyhydramnios. So on karyotyping, there was no abnormality. So at first glance we can say that the karyotype is normal. But due to the presence of many structural malformations on ultrasound, we proceeded with the microarray. So on microarray we see that there is gain on chromosome 17. The size of the gain is around 16 MB, and there is a loss on chromosome 9. The size is around 17 MB. So looking retrospectively, we thought that the material from chromosome 17 has gone to chromosome 9, but due to almost similar banding pattern, it was not diagnosed at the first time reporting. So the microarray in this case gave us the final diagnosis that the baby is having a imbalance involving chromosome 9 and chromosome 17, and this is a postnatal picture of the baby. So as you can see, the baby is having dysmorphism. The development of the child was also delayed. Case 2, so this was a 31-year-old female, second time pregnant. Previous child had trisomy 21, so they came at 16 weeks 6 days. Ultrasound was normal. Then the couple opted for amniocentesis for karyotyping as well as microarray. Fetal karyotype was reported as normal, but microarray showed a 1.4 MB loss at 17q12. So this deletion is associated with renal abnormalities, diabetes, genital abnormalities, neurological abnormalities. such as intellectual disability, autism, and speech delay. So, since the first ultrasound was normal, in 30% of cases it can be inherited from one of the normal parents, and there is intrafamilial variability. Suppose one of the parent is normal and the parent from which the copy number variation is inherited may be entirely normal, but the fetus can have any of these mentioned abnormalities. Then we did the repeat ultrasound after 3 weeks, which showed the presence of multicystic kidney on the right side. So in this case, only the detection of microdeletion could not reliably predict the clinical features in the fetus. As in the first ultrasound, there were no abnormalities. So it is challenging to counsel the parents regarding the implications if we come across these type of findings. So in this case, review ultrasound helped us to clear the picture regarding the fetal prognosis. Then third case, in this case there was fetus at 14 weeks. There was presence of cystic hygroma. There is left diaphragmatic hernia, which was also confirmed by postnatal examination. There was also history of one spontaneous first trimester abortion. We did karyotyping and translocation between, so a marker chromosome was detected. So at first glance we cannot say that this marker chromosome has originated from which chromosome. So then we did microarray in this case also. So we saw gain on chromosome 11 as well as chromosome 22, and mother was showing translocation between chromosome 11 and 22. So this is typical finding of Emanuel syndrome, in which we see a marker chromosome that is composed of a part of 11 and 22, which has originated due to during gametogenesis because of presence of balanced translocation in the mother. And this is the most common chromosomal abnormality, recurrent chromosomal abnormality, which is seen in translocation carriers. So the points to consider when we are offering prenatal microarray is that microarray can detect submicroscopic gain or loss which is present on any chromosome. So it is recommended for all cases undergoing prenatal diagnosis. The detection rate is 6 to 8% in case of fetal malformations and 1 to 2% when there is no fetal malformation. Diagnosis rate will also depend on the type of malformation and the organ system affected. But pre-test and post-test counseling is must to explain the uncertainties which are associated with this test. Now, thank you for patient listening.
Thank you, Dr. Deepti. It was that nice talk. Now, may I now invite our next speaker, Dr. Manish Kumar Singh. He is a graduate and a postgraduate of KGMU and has done his MD pathology and has done his postdoctoral fellowship in cancer cytogenetics. He is currently an assistant professor of hematology at SGPGIMS. He is also in charge of cytogenetics lab and myeloma lab. Dr. Manish.
So good evening everyone. I would like to thank the organizers, especially Dr. Neetu Nigam ma'am, for providing me the opportunity. So my talk would be on basically predominantly would be on cancer. It includes mostly hematological malignancy and some solid tumors. So I think we have gone through this. So just to revise the definition, so cytogenetics is basically the study of chromosome numbers which are present inside the cell. So it is a genetics which is based on cell. So one of my teacher used to call it as microscopic genetics, and now we are moving towards the molecular genetics. So just a background for those MBBS students. So it was in 1882 when we first illustrated the human chromosomes, the chromatin and mitosis. And if you look back, so till 1952, till 1923 we were of the view that there are 48 number of chromosomes inside a cell. In 1952 there was an accident in the Roosevelt Park Memorial Institute lab, and we got to know about the properties of potassium chloride as hypotonic solution, and it changed everything. So in 1956 we got to know that it is actually 46 number of chromosome which we have inside a human cell. And if you recall, in 1953 Watson and Crick already described the DNA structure. So the structure of DNA was described well in advance when we got to know about how many number of chromosomes do we have inside a cell. So after that there were changes in the staining technique, and in 1972 came Janet Rowley. So Janet Rowley was working predominantly on Down syndrome till then, and she had migrated to some other city, and where the clinician was actively involved in the treatment of leukemia patients. So Janet Rowley was the person who described the translocation 922, the identification of the chromosomes. So Philadelphia chromosome was identified by in 1962 by two cytogeneticists, but the identification of the chromosome. So if you look back the literature which they have published in 1962, they have stated that it could be an additional sex chromosome. It could be a additional Y chromosome. They have speculated that it could be additional Y chromosome rather than a translocation involving chromosome 9 and 22. But subsequently, when they got to know that there are female patients as well of CML who did have that additional chromosome, so they got to rethink that it is actually a translocation, and it was Janet Rowley in 1972 who told that it is a translocation 922 which leads to the formation of Philadelphia chromosome. Apart from that, she also was instrumental in describing the translocation 821 and translocation 1517. All these three are the myeloid neoplasia defining chromosomal abnormality. So, and she expired in 2013, and in 2011, because of her innumerable work on CML, she was offered the Presidential Medal in US. So how do we utilize genomics in cancer? So it could be as a diagnostic marker, it could be as a prognostic marker, or it could be as a predictive marker. So for example, the presence of same translocation 922 BCR-ABL1 fusion in a setting of myeloproliferative neoplasm is diagnostic for chronic myeloid leukemia. But the same presence of translocation in a setting of acute lymphoblastic leukemia is not a diagnostic marker. It is actually a prognostic marker which suggests that this patient is a high-risk disease, and if we treat these patients with a TKI-based therapy, then it would become a predictive marker. Similarly, in solid tumor, if you look at in breast carcinoma, the HER2 amplification, which is actually, when we do it by IHC, it is actually a marker for adverse prognosis. But when we treat those patients with trastuzumab, which is the first monoclonal antibody used in the cancer, so it becomes a predictive marker. And now with the use of molecular genetics, we are getting so many number of VUS, that is variant of uncertain significance, which we are not sure whether they are diagnostic, prognostic, or predictive. So in the recent past, this slide shows the recent classification, WHO classification of various neoplasia like soft tissue sarcoma, then AML, then lung cancer, then breast, and then CNS tumors. So if you look at more and more number of genomics is being incorporated in the classification of these tumors. So during my fellowship I did most of the work on the solid tumor, but right now I am just doing hematology. So just a few cases from the solid tumor. So in breast carcinoma, it is the FISH for HER2 new amplification, which is established as a marker for the high risk as well as for the treatment with the monoclonal antibody, that is trastuzumab. So there are guidelines from the American Society of Clinical Oncology. I think there are separate lectures for this on that. This is the criteria which is used to identify whether it is HER2 amplified or not amplified. And then when it is amplified, so HER2 is a transmembrane receptor, and when it is amplified, there are more number of receptors on the cell, which eventually leads to the activation of the several transduction pathway, which leads to proliferation, increased survival, invasion and angiogenesis of the tumor cell. And now trastuzumab, which was the first monoclonal antibody used in cancer, now the same HER2 is used to devise multiple drug strategy across the tumors. And now we have novel antibody drug conjugates. Now we have a bispecific antibodies. We have immunotherapy based vaccines as well as neo-TKI are developed based on this strategy. Similarly, in lung carcinoma, the two key players are ALK and ROS. Both are again the transmembrane receptors, and again they lead to the activation of the several transduction pathway because of the translocation involving these genes. So what happens because of certain translocation involving these genes, there is constitutive activation of the downstream pathway, and the cell doesn't require any ligand or any hormone to progress or to proliferate. So now there are guidelines to perform FISH for ALK and ROS testing, and if the first step is to do the IHC, and if IHC result is positive or it is equivocal, then we must perform FISH testing for ALK and ROS gene rearrangement. So this is one of my case of my fellowship days. So he was a 67-year-old male, known case of lung carcinoma. Earlier he was positive for FISH for ALK gene rearrangement. He was treated for crizotinib for last 6-7 months, but there was persistent progressive disease in the lungs. So a rebiopsy was planned, and on rebiopsy we did a MET amplification. So MET amplification is one of the surrogate marker which is used to predict whether the patient is going to perform better with the TKI based therapies or not. So ALK rearranged lung cancer as well as EGFR mutated lung cancer, in a proportion of those patients, if they have MET amplification at baseline, there is increased chances they might not respond better to those TKI based therapy. So moving on to soft tissue sarcoma. So it was a 2004 table. If you look, this was the year when I got entry in the MBBS. So in 2004, these were the fusions which were described in soft tissue sarcomas, and EWSR is the key player. If you see, the same EWSR gene rearrangement lead to so many type of histology. So if there is any pathologist, so he can understand, you have to perform EWSR rearrangement in so many histological type of the soft tissue sarcomas. And lastly, the CNS tumors. So this is a 52-year-old male with left frontoparietal SOL. Now the histology is like what we call as fried egg appearance or chicken wire type appearance. And on IHC, by using IDH R132H clone, which is recommended for the IHC, so there was positivity which suggests that the IDH gene is mutated, then ATRX gene was retained in the nuclei. So presently the newer WHO classification recommends at this point of time you must perform FISH for 1p19q deletion, and if this is positive, then the final diagnosis will remain the oligodendroglioma IDH mutant. And now there is enough literature which suggests even if the morphology, the histology is not a classical oligodendroglioma type, but the molecular feature like IDH mutation and 1p19q deletion are present, then you must classify it as an oligodendroglioma. Now moving on to the hematology. So this was a 36-year-old female, and if you can look, this is a bone marrow aspirate smear. You can see there are occasional blast. I think this is the only cell which can be called as a blast. Otherwise all those cells are the monocytic precursors or maturing myeloid series of cells. So she presented in our emergency, had a consolidation in both lung fields. So her TLC was raised, there was bicytopenia, so peripheral blood film shows monocyte and monocytoid cells, occasional blasts were there, flow cytometric immunophenotyping was bone marrow aspirate was done, and it shows 3.2% myeloid blast and 24.5% monocytic cells. So because there was a leukocytosis young patient, so we thought that it could be a CML. We did a BCR-ABL FISH which came out to be negative. Then because of the presence of 3.2% blast, there are so many monocytes are there. So we did a FISH for inversion 16, that is CBF beta gene rearrangement, and it came out to be positive. So in recent classification, in the last year classification from the WHO has revised its threshold to diagnose AML, and it came down to be there 10%. So this was the case where actually the blast percent was less than 10%, but actually it was an AML. So again, this was a case of AML where we got a monosomy 7 and a 10-11 translocation. So 10-11 translocation leads to a gene rearrangement of a gene called as KMT2A or MLL gene. It is a very notorious gene which has more than 80 different fusion partners, and if you devise a technique based on molecular strategy like PCR, it would be very difficult to screen all those partners. So basically what the present strategy is to use a dual fish. Dual fish means use a MLL break apart probe, then use a specific fusion probe, or what we use is a fish plus karyotype approach to diagnose these cases. It is important to diagnose these patients because except for AML with 9-11 translocation, all other AMLs are high risk and they are potential candidates for allogenic stem cell transplant. So this was one of our case of 27-year-old male presented. He came from Bangladesh to us during my fellowship time. So it was morphologically acute promyelocytic leukemia. Acute promyelocytic leukemia is an emergency for a hematologist. So everything was suggestive of acute promyelocytic leukemia except the PCR, which was negative for PML-RARA fusion, as well as the fish report, which was also negative for the PML-RARA fusion. But on the fish, there was an extra green signal suggestive of a gain of RARA gene. So we did a karyotype. On karyotype, there was a 11-17 translocation, which suggests that this patient is a variant RARA translocation, a APML with a variant RARA translocation. And normally the APML patient, being a medical emergency, actually they are a medical emergency, but they are absolutely curable malignancy. You can treat them with a specific targeted therapy called as ATRA and arsenic. But if those patients have a translocation 11-17 or variant RARA translocation, so these patients don't respond to the ATRA-based therapy. You need to treat them as a conventional AML protocol. So, and this was one of my favorite case. So it was a 6-year-old male presented with bicytopenia. There was some facial dysmorphism which was ignored at the time of the presentation. The peripheral blood and bone marrow show 30-40% blast, so it was supposed that it is a clear-cut case of acute leukemia. Flow cytometry showed AML with aberrant 19 expression. The karyotype shows classical 821 translocation, which is the most common recurrent cytogenetic abnormality in AML, and it is associated with favorable risk. But what was odd was there was a presence of additional chromosome 21. So additional chromosome 21 is also a secondary cytogenetic abnormality which may you encounter with 821. Means the 821 clone may have a additional 21 chromosome. But when the resident called us and told me that he has got facial dysmorphism, so challenge was that to prove that whether this additional chromosome 21 was a secondary cytogenetic abnormality or actually it is a patient, he is a patient of Down syndrome who subsequently have developed AML with 821 translocation. So we did a research in the database. So we found that AML patients with Down syndrome who develop AML, they don't have translocation 821. There are only anecdotal case reports which suggest that Down syndrome AML with 821 exists. So, but we have to prove that it is not a Down syndrome or it is a Down syndrome. So what we did, we did a cytoreduction for that patient. After the blast came down in the peripheral blood, we collected the peripheral blood and did a PHA stimulated peripheral blood karyotype. And as you can see, there is there is no 821 translocation, but there is a gain of chromosome 21, which suggests that it was actually a case of Down syndrome with AML with 821 translocation. So it is important to distinguish whether the patient is Down syndrome or not, because Down syndrome AML patients don't require that much amount of aggressive chemotherapy that we use usually in the AML patients. So this was a patient of leukocytosis with splenomegaly, 67-year male. Everything was suggestive of CML CT. The qualitative and quantitative RT-PCR for BCR ABL fusion was done, which came out to be negative. And when we did a FISH, so we got a fusion for 922. So approximately 4 to 5% of the CML patients don't have conventional transcripts which can be picked up by the PCR, and you might require a FISH to identify those patients. Again, a similar spectrum. Leukocytosis, splenomegaly, a relatively younger patient. So we did a everything was suggestive of CML. We did a FISH for 922. Again, it was negative, but there was a gain of BCR gene. There are 3 green signals. So we did a karyotype. On karyotype, there was a 422 translocation. We did a match metaphase with a PDGFR alpha gene, which houses at the chromosome 4, and it came out to be the rearrangement of the PDGFR alpha gene, BCR PDGFR alpha fusion. And actually, these are the patients which can be targeted with TKI based therapy. So this patient was treated with TKI based therapy. Now moving on to the another case, 16-year young boy, easy fatigability, pain abdomen, repeated transfusion. Physical examination was within normal limit. There was nothing abnormal grossly. Family history was not significant. Pancytopenia was there. There were occasional circulating blast in the peripheral blood. Bone marrow aspiration was hemodiluted, but on flow cytometry we did identify 2.6% myeloid blast, and this was a biopsy. So biopsy was hypercellular bone marrow biopsy, and there was numerous megakaryocytes which were showing dysbiosis. So we did a karyotype. On karyotype there was a monosomy 7. So what was this case? So actually in such a scenario it would be a MDS called as myelodysplastic syndrome. So we thought that it is a case of childhood myelodysplastic neoplasm. So but there is a caveat. So there before diagnosing a childhood MDS you have to exclude out non-neoplastic causes of cytopenia. The list is as shown here. So just we thought that it could be a case of bone marrow failure syndrome. We did a stress cytogenetics, that is mitomycin C induced chromosomal stress test, and as you can see in the circles there are presence of triradials and tetraradials, which suggests that this patient was actually a case of bone marrow failure syndrome who presented with in the spectrum of the MDS. And it is important to diagnose these patients because such patients require the definitive treatment is allogenic stem cell transplant, and while doing allogenic stem cell transplant you have to recondition your you have to re-strategize your conditioning therapy. Otherwise the normal conditioning therapy which we use in the transplant patient which will lead to the deterioration of different organs of these patients, and we may lose patient during the transplant. So again, a 6-year-old male, severe aplastic anemia. He was planned for allogenic stem cell transplant. There was a full match sibling of the patient, but on stress cytogenetics, again there was presence of triradials, tetraradials. We did a clinical exome sequencing of the whole family, and there was mutation in the FANG gene. So again, in aplastic anemia, the definitive treatment is transplant, but you cannot transplant such patient with a sibling who also has the same mutation. So identification of these abnormalities is important both for the management point of view and for the patient family point of view. So moving on to the lymphoid malignancies. So BALL, I will not go into the detail of this. So these are the genetic risk group of the BALL. So there is classical difference in BALL. In childhood BALL, most of the BALL are standard risk or good risk, and in adult BALL, most of the BALLs are high risk. So this was one of our strategy to diagnose BALL by doing triple probe FISH strategy. We used 3 different probes, 1221 MLL and 922 probe, and we were able to identify most of those patients. So based on the other work, we identified that in the high hyperdiploid BALL there is a repeated pattern of the chromosome gain, and we proposed that rather than using the 4, 10, 17 chromosome enumeration probe, which is widely used across the world for identification of high hyperdiploid in BALL, it is better to use chromosome X618 or X614 or X617 enumeration probe, which can eventually pick up more number of hyperdiploid patients. So based on this, we devised our own strategy in SGPGI. We are using a 5 probe strategy, including 1221, 922 MLL plus IGH and CRLF2 probe, and by this we are able to identify most of these cytogenetic risk group in the BALL. Just a couple of cases. So this was a case, as you can appreciate, the morphology is like the Burkitt leukemia, but while doing the FISH we identified that this is a patient of 1221 translocation BALL. Then this is another patient of BALL. There were presence of gains of different number of genes. But when we did the karyotype pattern was not classical of the high hyperdiploid. It was actually the modal number was actually into the high hyperdiploid group, but the pattern was unusual there. So it was actually a endo reduplication of the low haploid group which presented as a high hyperdiploid group. So such type of patients are high risk. And then this was an unusual case. So 59-year-old male, leukocytosis, splenomegaly, 72% blast, 2% basophil. It was assumed that this is a case of blast crisis. Flow cytometry showed lymphoid blast, so it was assumed that it is a case of lymphoid blast crisis in CML. But when we did a FISH, so we identified that not all the tumor cells contain the BCR-ABL fusion. It was present in only subset of cells. So actually it was a case of pH positive BLL rather than the lymphoid blast crisis in CML. So this was our case of pH like ALL, which is a relatively newer entity in BLL and is associated with high risk. Now moving on to the lymphomas. So in lymphomas there are numerous genetic marker which can be used across different histological types. So this is a case of mantle cell lymphoma which was diagnosed based on the IGHCCND1 fusion probe. Then diffuse large B cell lymphoma. So this was a difficult case to put into the category. So the location was like that. It was a case of Burkitt lymphoma. The mass was in the duodenum and jejunum junction. Morphology was high grade, but CD10 was non-contributory. So we were on the back foot whether to put it as a Burkitt lymphoma or not. So actually it was a case of high, what recently WHO say high grade B cell lymphoma with c-MYC rearrangement, and we cannot put it into the separate category. And then this was another case of DLBCL where we did a c-MYC and BCL2 and tried a double hit B cell lymphoma. In T cell lymphoma, this was a case which was referred as TALL, but actually it was a case of hepatosplenic T cell lymphoma, and to prove that we did a different type of deletion 7q probe which is used in myeloid neoplasm, and we showed that actually it was a case of hepatosplenic T cell lymphoma with isochromosome 7q amplification, which is a common entity in hepatosplenic T cell lymphoma. And now the last is the multiple myeloma. This is our strategy to diagnose multiple myeloma. We use a plasma cell enrichment technique to enrich the sample with the plasma cell, and then we subsequently perform stepwise FISH pattern. These are the different risk stratification of the myeloma, and this was one of our case which now we called as a double or triple hit myeloma. So to conclude, the evolution and development of the existing knowledge in cancer is actually a continuous process rather than a distinct step. We should not jump on one of the technique and assume that everything can be diagnosed or can be known by this technique. And cytogenetics actually provide us the opportunity to look directly into the disease. As I said, it is a type of microscopic genetics, and it identifies the aberrations which still are disease defining and which can modify the treatment decision. However, the techniques still are labor intensive. They demand expertise which eventually has a long learning curve, but the opportunities for us lie in improvising those protocols by devising our in-house protocols and making a cost-effective diagnosis. Thank you. So good evening everyone. I would like to thank the organizers, especially Dr. Neetu Nigam ma'am. So good evening everyone. I would
genomic tools for chromosomal microarray, next generation sequencing, QFPCR, qPCR for clinical application in India, and continuously working more than a decade. Major expertise in reproductive genomics with experience of more than a decade and worked in organizations like MedGenome Labs and Perkin-Elmer Genomics. At present, she is General Manager in the Department of Rare Disease and Reproductive Genomics at Unipath Specialty Labs Limited.
Hi, good evening everyone, and thank you Dr. Neetu for inviting me on this event, and thanks again for accommodating me in a day prior. So because of my personal commitment, I need to go to tomorrow chromosomal microarray. In 2015 at KEM Mumbai, I gave a session, and that was the session title was Beyond Karyotype. That time, microarray was picking up in India in genomics, in reproductive genomics, in cytogenomics, and I was very happy, and the audience was very amazed to hear about microarray. Today again I am giving a session, and the topic is Beyond Microarray. So today I am really happy to see that every clinician, every gynecologist, every fetal medicine consultant, apart from the clinical geneticist, are understanding the importance of microarray, and now why this microarray has picked up so much, that I will try to cover in my talk, and then how these evolution of techniques had happened. Don't worry, I will not take you through the those chart that who discovered the cytogenetic karyotype and how the microarray had, just a glimpse. And then why there is a need of moving from microarray. Then what is that which will detect the structure variation apart from microarray? And this is the low pass whole genome sequencing. And then what's the way ahead? So I hope that after 5 years, again I'll be talking on the finding of structure variations, copy number variation, and maybe beyond low pass whole genome sequencing. So in 2007, this was a breakthrough of year in the cytogenomics, because the Science magazine that published that CNVs, copy number variations, are not only responsible for creating a difference, phenotypic difference among the individuals, it also leads to diseases. And if you see this slide, there are millions of CNVs across the human genome, and we need to assess that. To do that, so what are these structured DNA variations? Just one slide. We all know that these are the variation in a DNA if the region is larger than 1 kb, and it includes the deletion, duplications, inversions, translocations. So that comes under the copy number variations. And these structure variations, we have already seen, they are involved in various diseases, cancer, common behavioral diseases, ASD, neurological, so many ultrasound anomalies. So the evolution of techniques happened, and first of all the karyotype, but it had its own limitation. The resolution is not more than 5 to 10 MB, and a beautiful case was represented by Dr. Arundhati, and she represented that how it, that one case they have missed it in the karyotype. Even the size of the deletion was more than 10 MB. I think it was by Dr. Deepti, sorry. And the karyotype cannot detect the balance it can detect the balance translocation. It is still today the gold standard technology in cytogenomics. Reason being, it's the only technology which detects the balance translocation beautifully, and it's very cost effective. However, it's time consuming, and it needs an expert eye for the interpretation. It cannot detect loss of heterozygosity, absence of heterozygosity of uniparental disomy. So then another technique came into the picture, FISH, we all know that. So the resolution was good, it was approximately 1 MB, nowadays 80 KB, but it is locus specific, and we need to know prior the targeted regions, because at time it cannot screen beyond 5 anomalies. So either the 5 regions or 5 anomalies. So it is not a screening technology, it is a validation tool. I should have a prior knowledge which region I am actually looking for. Then came a revolution with the help of microarray. Now I can screen all 23 pair of the chromosomes. I can detect smaller deletion duplications. The resolution is also high. And not only that, I need not to culture the cells. I can directly do it from the sample, amniotic fluid. I can isolate the DNA. I do not need to culture the cell. I can isolate the DNA from the blood. And this technology again brought the revolution, because now I can tell which are the genes which are being deleted or duplicated in that particular region. And it was the only technology which could report loss of heterozygosity and uniparental disomy. And the turnaround time, if I tell you practically, it will not take more than 7 days in reporting a case from getting the sample. So 2.5 days in the wet lab and 2 to 2.5 days with the data analysis team. So that's kind of a revolution was brought by microarray. But every time in all the presentation what we are observing and in all the literature, we see that all the 23 pair of chromosomes can be analyzed. It does the genome-wide screening. Then why does these marks? So, but still, microarray can also not detect each and everything. Why? Why is it so? Why microarray cannot detect all type of copy number variations which are present? So, there is a reason behind that. Dr. Dipti presented how we do the microarray and what are the principles behind microarray. So, it is a probe-based technology. So the probes are printed on the chip. So it's like your mobile, You have a kind of data size which beyond that you cannot input the information, the memory size. Similarly, when it comes on the microarray, the chip has a limited space. So I become selective because आप क्या कहते हैं कि मेरे मोबाइल का ना मेमोरी खत्म हो गया तो I'll delete certain photographs or I will not take unnecessary photographs. So similarly, in microarray, when I am about to print the probes, I select the known disease regions. I select the most relevant regions because I have to pick up the anomalies. So it's a chip-based, so probe-based, and it's a biased technology. The resolution is 50 kb. So if there is a smaller deletion duplication, it cannot be picked up by that kind of confidence. Majorly, 3 platforms are very well, famous or accepted in microarray: Illumina, Agilent, and Affymetrix. We will not go in detail about it. But in India, maximum people are liking and following Affymetrix microarray. However, Agilent has its own advantages. But somehow, during the course of this journey, they have lost their uniqueness. So, if I explain microarray chip in a diagrammatic way, this is how the probes are being designed against a specific region of each chromosome. So now can we say that microarray is covering all the chromosomes unbiasedly? No, because we are selecting specific regions. So in case if I have my targeted region or the disease associated region in this particular area of chromosome 6, it will be missed because I don't have probe for that. Okay? Or if I explain it in a very simple way, the gene is a very big, it is of big size, 1 MB or 2 MB. And if I have the deletion or duplication in this particular area, I am sorry, I am not using a pointer. Okay. So is it visible? Okay. So if I am having any deletion duplication in this particular area, but the probes are not there, it will not be detected. It means you will get a normal microarray report. And this is why it happens. Sometimes you see the phenotype, you can sense it out. It is some kind of micro deletion, but you get a normal report. Now the challenge is, should I go ahead with the whole exome sequencing? Should I go ahead with the MLPA? Maybe the size is very small, or maybe, the array has missed it. So then what should we do? So there is a new technology which you must Few of you might have heard different webinars, few of you might have attended the conferences, and few of you might have actually used it. So that is by next generation sequencing, and this is called low pass whole genome sequencing. So in this technology, they take the DNA and sequence it unbiasedly. So they are not loading it on any particular chip. They are sequencing the entire DNA, intronic, exonic, every region. So the entire DNA is being sequenced. So that is why if the disease causing region is in this particular region of chromosome 6, I can pick it up because I am not biased. So that is what we call low pass whole genome sequencing. It is being done by a technology called next generation sequencing, and any platform can do it. So what is this low pass whole genome sequencing? So in this low pass whole genome sequencing, they do the pair end reading. So different kind of fragments of DNAs are being synthesized, and forward and reverse end, both the ends are sequenced. And from the reference genome, these reads are being aligned. And if there is a miss, we call it as a deletion. If there is extra, we call it as a duplication. Not only that, you detect aneuploidy, you detect unbalanced translocation, you detect mosaicism, and the CNVs with the help of the low pass whole genome sequencing, and it is an unbiased one. So I do not have a tendency to miss any particular CNV if my bioinformatician had done a good job. Okay. So that is the advantage of low pass whole genome sequencing. There was a one company which launched it in India 3 years back under the name CN Genome, copy number genome, that was their trademark. But because of the cost factor, it couldn't be that successful. Okay, so there were many publications which wherein people have already used low pass whole genome sequencing to detect the structure variations, and they have identified that all pathogenic copy number variations which were detected by RACGH were being picked up by this same technology. Low pass whole genome sequencing, when I say, it means I have done it at 5x or 10x. Maybe sometimes in future we can discuss in detail about the coverage and depth and low pass and all that. Today, due to the time constraint, I will not go into the depth. There were more VOUS which were being picked up by this low pass whole genome sequencing, like I told you, because it is an unbiased. So I am not limited by my chip size. Okay. And like Dr. Shruti said, that this VOUS has also its own significance, so we need to pick up even the VOUS. Trisomy and mosaic CNV samples were also being picked up by this low pass whole genome sequencing, and it has a very good resolution. Even if the deletion duplication is less than 25 kb, it can pick it up. So if I summarize, the low pass whole genome sequencing for CNV detection, you sequence the DNA and analyze at the 5 times, that is called 5x low pass whole genome sequencing. It detects the copy number variation throughout the genome, and it is a pro-free approach. So even if the copy number variation or the deletion duplication is less than 25 kb, it can pick up across the entire genome. Whereas if we talk about the microarray, the coverage is limited to the probe locations. It has increased the precision of CNV by defining the breakpoints. What is the exact breakpoint, which helps us to understand the clinical significance of those deletion and duplication. It can also detect the unbalanced structure variants, aneuploidy and UPD. And to some extent, in some literature, they have also shown that by low pass whole genome sequencing, they were able to pick up the balanced chromosomal rearrangements. Till now, only karyotype is able to pick up that. So that not the microarray, but low pass whole genome sequencing was successful in picking up the balanced chromosomal rearrangement as well, but it is till now it is in research. However, apart from that, everything else can be picked up by low pass whole genome sequencing. So what are the indications? Indications are same: intellectual disability, global developmental delay, multiple congenital anomalies, autism spectrum disorders, recurrent miscarriages. If you are getting any negative karyotype or microarray results and you're suspecting a CNV disorder, rare disorders with normal gene sequencing results. So all these kind of abnormalities can be easily picked up by the low-pass whole genome sequencing. So whenever you are using microarray, it can be done by low-pass whole genome sequencing. So advantage of low-pass whole genome sequencing over chromosomal microarray or traditional karyotype is that it increases the resolution. Why? Because it can pick up the deletion duplication even if the size is less than 25 kb. It is not hybridization based, it is not probe based, it is not limited by the size, so it's an unbiased analysis. So I do not have a doubt when I get my microarray report, oh, I have done it on the Illumina, maybe Illumina doesn't have that probes. I did it on the Affymetrix, maybe Affymetrix doesn't have that probe. The chip is, selective. So I'm not bounded by that thing. And so it is an unbiased analysis, and so it decreases the odyssey of the test. So once you know that it is negative for CNV, I can think methylation, I can think something else beyond CNV. And it covers across the genome, and it can easily pick up the mosaicism. So that's the another beauty of low-pass whole genome sequencing. However, there are few points to consider. This is not the same test as regular whole genome sequencing, because regular whole genome sequencing is being analyzed at 30x, the higher depth. So even you can pick up the single nucleotide change. So when you do a 30x whole genome sequencing, you can pick up the single nucleotide variations, aneuploidy, translocations, everything, okay? But this is not that. You are reducing the depth, you are just analyzing it 5 times. This gives me a confidence to pick up the structure variation, not the SNVs. So we do not analyze the single nucleotide mutation by this test, and it is a costly affair in comparison to microarray. So if microarray costs somewhere around 10,000, it will cost somewhere around 25,000. But like I told you, in 2015, when we were giving the microarray, it was costing somewhere around 22,000, and the karyotype was costing around 3,000, and people used to ask, Anu, कौन लेगा ये test? 25,000 में क्या? कौन करवाएगा? So I never imagined that day, कि one day everybody will be using microarray rigorously. So similarly, I'm hoping that these companies will bring down the cost of low-pass whole genome sequencing as well, and we will be talking about what additional we are getting in low-pass whole genome sequencing. So thank you for being a patient listener. I know I am the last speaker and you must be in hurry to go back home. And so what else? What next can be done? So ye dil mange more. Today we were discussing during the lunch time that why can't we have one test जिसमें methylation भी हो जाए, जिसमें intronic region भी हो जाए, जिसमें SNPs भी हो जाए, और जिसमें structure variation भी हो जाए. There is one. It's coming. So maybe by this year end, there is a company which is going, it is not Illumina, not Affymetrix. They are planning to bring down this whole genome sequencing at a low pass 10x with the capability of picking up SNVs, methylation, dark regions, and aneuploidies. Thank you.
Thank you, ma'am. I am sure the spectators will agree that this session was indeed captivating. I would now like to express my sincere gratitude to our honorable chairpersons for the day, Dr. Sharat Singh sir and Dr. Neetu Nigam ma'am, for gracing the occasion. I would also like to express my heartfelt gratitude to our erudite panel of speakers, Dr. Dhavendra Kumar sir, Dr. Arundhati Sharma ma'am, Dr. Deepti Saxena ma'am, Dr. Manish Kumar Singh sir, and Dr. Anu Yadav ma'am, for sharing their knowledge and experience with us. I would also like to thank the participants and audience for their interest and enthusiasm. We would now like to honor our delegates with mementos as tokens of our gratitude and reverence. I would like to request Dr. Neetu Nigam ma'am to kindly present the memento to our honorable chairperson for the session, Professor Sharad Singh sir. Ma'am, please. We are privileged to have you, sir. Thank you, sir and ma'am. I would now like to request Dr. Frenny Sheth ma'am to kindly present the memento to Dr. Arundhati Sharma ma'am. Ma'am, please. Thank you for gracing the occasion, ma'am. Thank you, ma'am. I would now like to request Dr. Rajni Gupta ma'am to kindly present the memento to Dr. Deepti Saxena ma'am. Ma'am, please. Thank you for gracing the occasion, ma'am. I would now like to again request Dr. Rajni Gupta ma'am to kindly hand over the memento to Dr. Anu Yadav ma'am. Ma'am, please. Thank you, ma'am. I would now like to request Dr. Sharad Singh sir to kindly present the memento to Dr. Manish Kumar Singh sir. Sir, please. We are privileged to have you, sir. Thank you, sir. With this, we come to the culmination of day 1 of this international conference. Day 2 will take place at the same venue tomorrow. We are eagerly waiting for your wholehearted participation tomorrow as well. Thank you, everyone.